Yeah. Good afternoon, everyone. Welcome to yet another program by the Association of Oral Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch. Yes, this program is unique as we have different specialists speak to us on a subject which is common to all of us. Yes, it is a privilege to present these wonderful speakers and moderators who have agreed to share their knowledge with us. I would like to thank our chief guest and the special invitees who have agreed to be a part of this program to share their thoughts about this concept of working together for the benefit of the patients. Friends and colleagues, we won't take too long before we start this academic scientific feast. Now, it's my pleasure to invite Dr. Shalu Rai, the Honorary Secretary of Indian Association of Oral Maxillofacial Radiology, to share her thoughts.
Good afternoon, everyone. I am thankful to Dr. Jimson, Secretary, State Secretary, Oromaxillofacial Surgery, for making me the part of this O Symposium. I'm honored to be participating in this symposium, especially the topic, which is very, would be very enlightening to the delegates who have enrolled and who have registered for this symposium. I am also thankful to the president of the oral maxillofacial surgery and even to all the committee members who have made me a part of this program. And happy learning in this pandemic condition. Thank you very much.
Thank you,
Dr.
Shalu Rai, for your support from your specialty as well. Thank you. And now we have one more special invitee, the General Secretary of IACD, the Endodontic Society, Dr. Mohan Kumar, and I invite him to share his thoughts. Dr. Mohan.
Good afternoon, all. It's been a pleasure to see you all. And it's always nice to learn. And as far as this topic is considered, you have a fantastic moderator who's from our branch. And what more to say? Just to see, listen, and learn from you all. Thank you. Have a great evening.
Thank you, Mohan.
Thank you, Dr. Mohan, for accepting our invitation and joining us.
Pleasure is mine, sir.
Thank you. And the next special invitee is Dr. Nadeem Jeddi, the General Secretary of Indian Association of Oral Maxillofacial Pathology. But he sends his best wishes for this program. He got held up with some program, so he's unable to join us. Now, you heard all these special invitees speak. Now it's my pleasure to invite our very own Dr. Veerabagu sir, my teacher, the president of Association of Oral Maxillofacial Surgeons of India, to share his views and thoughts about the symposium. Welcome.
Thank you, Jim. Good afternoon, my dear colleagues and students. I bring you all warm greetings from AOMSI. Once again, under the leadership of Dr. Reena John and Dr. Jim, another wonderful program is being conceptualized and being done by Jim. Congratulations, Jim, for your team. Happy to see specialists from all the other branches. And Cysts of the Jaw is a dear topic to me. And I would tell my maxillofacial junior colleagues, this is one particular specialty. In terms of treating major cysts, there is no major overlap. You are the specialist. You are going to deal this. So if your concepts and treatment philosophy is good, you can make a wonderful name out in your career in wherever you are practicing. Just 3 days back, why this particular symposium is going to be very important, I will share a small anecdotal story. Just 3 days back, I received a WhatsApp just for a dentigerous cyst. A fellow colleague has just done a resection of 2 centimeters of the angle of the mandible and put a recon plate and the iliac bone graft, and which has got infected. And believe me, the patient is a well-educated PhD also. I felt so bad because this is not the time where you go and do a segmental resection for a dentigerous cyst and put a bone graft. I think today's topic is going to throw more light with the contemporary evidence And I'm sure we all will take good points. And also, I'm happy to see people from oral medicine and oral pathology, because they are going to tell what is the where it is and what is the level we should resect. And oral pathologists are going to tell us and what kind of nature of treatment we should do it. And of course, the endodontic people are going to tell us how we have to preserve the teeth also. So many thanks to Candy and his colleagues. I think I can see his whole South End Symposium here. Looks like Jim has somehow managed to hijack his entire crew here. So thank you for your generosity, for sharing your knowledge and time. And my special thanks to the oral pathology and oral medicine secretaries and endo secretaries, and also my dear friend Dr. Kavita and Dr. Nalini and all other faculties. Thank you very much. Thank you, Jim, once again for the wonderful opportunity.
Thank you, sir. Thank you for taking your time off and joining us for this wonderful symposium. Now it's time to take off with the scientific program. Now we invite Dr. Suresh to take over and invite the moderate for the first talk. Over to you.
Dr. Jim. Good afternoon, everyone. So again, another success story from the AOMSI Tamil Nadu and Pondi chapter. With great efforts through the President, Dr. Reena John, and the General Secretary, Dr. Jimson, we have been having a lot of webinars every week almost. So we are very happy. And all these days, it was a single specialty webinars. And today it's a special day. We have got 3 specialties together. And it makes me a little nervous too, because we have all the general secretaries here, and my own Guruji, Dr. Veerababu, is here. So I can't afford to do any mistake. And all the speakers are going to be professors and HODs here. And I could see faces of stalwarts from the UK. So I'm seriously a little nervous, but I'm sure I'll be learning definitely a lot of points from the symposium today. So let me take the pleasure of introducing Professor Dr. Nalini Ashwath, who has graduated her BDS and MDS from Tamil Nadu Government Dental College and Hospital, Chennai, Tamil Nadu, in the branch of oral medicine, diagnosis, and radiology. I have always seen her as a very calm and quiet person with a smiling face permanently. She continued to stay in the academics after her post-graduation, and currently she is the professor and HOD of oral medicine radiology at Sri Balaji Dental College and Hospital, Chennai. She possesses about 42 national and 5 international publications at present. She has lectured extensively in various scientific forums. She has won Best Paper Awards 3 times in the national level specialty conferences. Her current interest is in the research related to oral mucosal lesions and management of orofacial pain. I now invite Dr. Nalini Ashwath to introduce the speaker, Dr. Bhagyalakshmi, and help her commence her talk. Over to you, Dr. Nalini.
Thank you, Dr. Suresh. Good afternoon, one and all. I take great pleasure in introducing Dr. Bhagyalakshmi. Dr. Bhagyalakshmi is a consultant and clinical lead in dental and maxillofacial radiology at King's College Hospital, NHS Foundation Trust, London. Her special interests include head and neck ultrasound, ultrasound guided fine needle aspiration, and core biopsy of salivary head and neck lesions, maxillofacial 3-dimensional imaging, radiological and ultrasound investigation and treatment of salivary gland disease, and radiologically guided techniques for the relief of salivary gland obstruction. Dr. Bhagyalakshmi had done her UG from Meenakshi Ammal Dental College, Chennai, and she is a Tamilian too. Thank you, madam.
Sorry, I was on mute. Thank you so much for inviting me to speak at the AAOMSI. It's such a privilege to be with the roots where I started my career in dentistry, and I'm really humbled by the invite. And I've learned a lot from my seniors in India, which I have actually extended my learning experience in UK. And I'm going to share some of my cases and my experience of how to use the imaging in the diagnosis and management of cysts. So what are the key pointers on use of imaging? The first thing is on the diagnostics. Is there a cyst, or is this an artifact, or is this a tumor? If you identify there is a cystic lesion, is it what type of cyst? Because obviously the management would be determined by the type of the cyst. Is it a radicular? Is it a dentigerous? Is it a keratosis? Trying to narrow down the differential diagnosis. And also we have to remember not all cyst-like lesions on imaging are cysts. So we have to identify the mimickers and try to do the right management for such lesions. So the differential diagnosis is broadly, you can classify them inflammatory, developmental, and you have non-odontogenic and pseudocysts. So the understanding of this sort of differential diagnosis helps us to identify the key features on imaging to make the diagnosis. In terms of choice of imaging, I cannot emphasize how important it is to have the plain films as your basic tool for diagnosis. Most of the cysts are identified on plain films. And in fact, it's the plain films which we are going to use on a long-term basis, even for the follow-up cases, to actually assess if there has been healing, progression, or recurrence of a lesion. However, with the evolving cross-sectional modality, we do have advantages of using three-dimensional imaging, particularly in selected cases where it influences your diagnosis or even the surgical outcome to decide on the surgical management of a case. So it needs to be chosen on a case-by-case scenario. We have cone beam CT scan, which is widely used, I would say, in the last decade. It has widely taken over the cross-sectional CT certainly in the maxillofacial aspects. And main advantages of cone beam CT over the CT is it's relatively low dose modality. It depends on the scanner. Obviously, the choice of scanner when you buy is very important to make the decision. And also it's readily available. It could be focused on the area of interest, so you can actually adjust the field of view size. And it's much more easier to interpret, because if you do a medical CT, surgeons who are reviewing their own scans, it's really hard to go through all the other structures on a CT. Say, for instance, your interest will be only in a mandible, but if you have scanned a wide area of tissue, then you are medico-legally responsible for it as well. So CBCT has got lots of advantage. Although it does have limitations because it doesn't really show the soft tissue. It's got poor soft tissue resolution. So it's very important you choose on case-by-case basis. And there have been selected cases where I prefer to do MRI as well. I'll try to share some of the cases as we go along, particularly when we think of recurrences happening at the surface of a lesion, where you expect a soft tissue involvement, particularly of keratosis, or if you suspect some sort of neural or vascular lesions in your differential diagnosis, MRI is quite a useful modality to apply. So in terms of the diagnosis, it's always a systematic analysis. That's the key mantra. You have to consider these factors, the clinical settings like the age of the patient, sex, ethnicity, how long the lesion has been present, because these all help you to narrow down the differential diagnosis. Of course, certain lesions have site prevalence. So is it at the apex of a non-vital tooth, or is it centered in between the tooth, or is it around the crown of an unerupted tooth, or is it actually displacing the tooth? Those factors have got a huge impact on our differential diagnosis. Size is important for your surgical planning, how minimally you can do, what aspects could you decompress the cyst before you go and take out. The shape, outline, and the effects, the radiodensity, again, it helps us to narrow down our differential diagnosis. For instance, if something has pushed the teeth apart, rather than getting at the apex of the tooth, then you know that it is unlikely to be a radicular cyst. So we'll go through some of the interesting cases to see how we can use these features to come to a differential diagnosis. This is just a pictorial representation of how a lesion could present. If you see a nice white corticated margin around a radiolucent lesion, you know that it is a slow-growing lesion, and that's how most of the cysts present. Of course, you do come across scenarios where you see a well-defined lesion, but you don't really see the corticated margin. You have to think of a couple of factors here. If a lesion is infected, then you may not see the corticated margin, or there could be lesions which are not well corticated. Some cysts, when they become large in size, they're not necessarily multilocular as the bottom end of the screen. Sometimes they have the pseudolobulated appearance. You don't really see the septations, but they have this nice scalloped margins. Again, even if it's a large dentigerous cyst, you get this pattern of pseudolobulated appearance. In terms of expansion, it's one of the major factors which actually help us to come down to narrow down the differential diagnosis. For instance, if you see a marked buccolingual expansion, you may be thinking of more an ameloblastoma or even a dentigerous cyst. Whereas you see a lesion which has got a growth potential along the cancellous bone with very little effect on the buccal and lingual cortical place, then you're likely to be dealing with an odontogenic keratocyst. Displacement of teeth, again, as I said, this is very important because you can see on the periapical radiograph, though you have a carious tooth, carious molar, you can actually see there is a well-defined lesion which is centered in between the roots and splaying them apart, actually telling that we are not dealing with an inflammatory cyst, we are dealing with a developmental odontogenic cyst or a tumor. Maxilla is even more challenging. If you look at the panoramic radiograph, it was an incidental finding. The first thing which catches your eye is the upper left 8 is developing at the wrong side. There is no obvious cystic lesion. A lesion, even a small lesion in mandible, becomes more obvious because of the thickness of the bone. You have a narrow buccolingual width. Whereas in maxilla, it's quite complex. You have a wide bone and there are a lot of superimposition of structures. You have the zygomatic arch, you have the spine of sphenoid, the pterygopalatine fossa, you have a lot of skull-based features superimposed on a panoramic radiograph, making it more challenging to diagnose lesions in maxilla. But sometimes the secondary features can be eye striking, and then when you pay a close attention, then you pick up the radiographic clues. As in this case, the upper left 8 was displaced quite higher up, and this patient actually had a cystic lesion developing below the crown, which turned out to be an odontogenic keratocyst. So most cysts are well-defined corticated unilocular radiolucency, and the main differential for that is radicular, residual if the source of infection has been taken out. If you come across on a developing tooth, you need to be thinking of paradental cysts, more common in the third molar region, buccal bifurcation cysts, which are more common in the molar region, buccal to the developing mandibular molars. You do come across dentigerous cysts with unerupted tooth. Lateral periodontal cysts are less common, but they are seen more in between the canine and premolar regions in the mandible. Okay, so it's very classic. I know that I started off with this simple case, but the clue is there is a well-defined corticated radiolucency at the apex of a non-vital tooth. Then you could be certain that this is a radicular cyst. Again, in terms of differentiating whether it's a cyst, whether it's a periapical granuloma or a periapical infection, as a rule of thumb, anything over 15 millimeters is most likely to be 2/3 of the cases are likely to be a radicular cyst, or a small proportion are going to be infections, or it could be a large periapical granuloma. Okay, but not always it's striking. When you look at this patient, the patient on the left-hand side has presented with a left facial swelling, clinically nothing very obvious, because the lateral incisors are or do have a developmental variation such as dents and invaginatus may not be very obvious clinically. But looking at the radiographic features, there is a well-defined corticated radiolucency which is centered on the upper left 2 and is kind of pushing adjacent teeth. You can see the upper left 3 is being distally displaced. In contrast to that case, there is another patient who presented with a swelling in the upper right maxilla. When you look at this, the upper right 2 and 3 are slightly displaced. Okay, and I think in this case, the cross-sectional imaging to see the extent and more details of the teeth have been helpful to narrow our differential diagnosis. You can actually see in the first case, the upper left 2 has dents in invaginatus, dents in denti, and a large well-defined radiolucency, which is actually surrounding the apex of a tooth. So that's a classic radicular cyst. Whereas the second one, they said, Baggy, is it a radicular cyst coming from the tooth? And I said, it's not, because if you look at the distance between the roots of the 2 and 3 on the axial plane, they are more splayed apart. And if you look at the lesion on the coronal and sagittal plane, it's centered more palatal to the roots. The apex has just got that pedial covering at the top. So I said that this is not typical of a radicular cyst. So I suspect this is actually a developmental odontogenic cyst, and it turned out to be a keratocyst. So it's very important to use the radiographic clues to narrow down your differential diagnosis. This is another interesting case, actually, which got to my attention only a few years after this particular radiograph. This patient presented to us with a swelling in the jaw. And at that time, the impression was there is a non-vital tooth, obviously, in the lower right quadrant. So I thought it's a radicular cyst associated with the lower right 4 or the 5. And they did an incisional biopsy, which also have come back as an inflammatory cyst. And the patient decided to leave it alone for quite some time. And then the patient came back a few years later with this sort of large expansive lesion in the mandible, where you can actually see almost within base radiolucency within radiolucencies. That means it's got uneven expansion and thinning of the cortical bone. And I'll show you cross-sectional imaging. You're dealing with a large multilocular lesion with scallop margins, with marked buccolingual expansion and considerable thinning of the cortical plates. And in fact, this turned out to be an amyloblastoma. The key, if I go back to the previous slide, the key diagnostic clue was that this lesion is not centered at the apex of the tooth, though there is a non-vital tooth right next to it. So that was the clue, because the clinical features, the radiological diagnosis, actually helps the pathologist to make that interpretation better, especially when the cysts are infected. It's very, very hard to arrive at a histological diagnosis, and providing the relevant clinical and radiological features help the pathologist to arrive at a better diagnosis. And I do see a lot of this because we come across a lot of Afro-Caribbean population, radicular cyst versus cemento osseous lesion. I feel sorry because most of these traits get unnecessarily root canal treated as soon as they see a large, well-defined radiolucency at the apex of the tooth. They start off with root canal treatment. In this case, you can see the cyst has been extracted for no reason, who's got stable dentition otherwise. And given a few years later, they start filling in with bone, and in itself confirms it's a cemento osseous dysplasia. You have to differentiate odontogenic cysts from other cysts, particularly in the maxilla. You can get benign antral cyst, mucus retention cyst within the maxilla, which can happen in the floor, medial or lateral bone, more common in the floor, versus a radicular cyst or an odontogenic cyst arising from the alveolar segment. If you look at the section of the panoramic radiograph on the left-hand side, there is a heavily restored tooth, and there is a large, well-defined corticated radiolucency. The key finding to differentiate whether it's an antral cyst or an odontogenic cyst, look for a corticated margin. If you see the corticated margin, then you are always convinced that this is odontogenic in origin, and then look for what is the potential or main differential diagnosis. If you look at the lesion on the right-hand side, there is a well-defined soft tissue density lesion within the antrum, but it doesn't have corticated margin. So that's very classic of a mucus retention cyst. I have to make a point. In maxilla, the air within the maxillary sinus makes it more radiolucent, whether you're looking at a panoramic radiograph or an intraoral examination or intraoral radiograph or even on cone beam. Air is the darkest, so as soon as a cystic lesion occupies the maxillary sinus, it looks more denser, it looks more opaque. We call it as a soft tissue density. So you need to be careful with the differential in the especially when they're associated with the maxillary sinus. This is another interesting case. By the way, I don't really report every panoramic radiograph taken. As you all know that as clinicians, we are very well trained to review our own radiographs. It's only some of the challenging cases come to me to say where we go from there. This patient is an 8-year-old boy who came to the A&E with an acute left facial swelling. And this was taken in our A&E department. That's why you can actually see they chopped off the mandible and they've exposed quite a lot of orbits. That's a wrong protocol done. But setting that aside, I don't know how many of you, as radiograph is something you see as what you can see. When you look at, is there a large radiolucent lesion in the mandible, or is there an apical infection in the in the left maxilla? It's really not obvious. But so the junior MaxVax trainees who saw this case said, "Oh, Baggy, I can't see anything." So I thought you better glance an eye what we are dealing with. Should we take this patient to theater? What's happening? He's got a facial swelling. So when I looked at it, I said the first striking feature to my eye is the upper left. 2, 3, 4, which are developing, have been pushed apart in comparison to the right-hand side. So clearly there is something happening in the left maxilla which has altered or displaced those developing teeth. And considering the patient was young and we're dealing with a more sort of cystic or an infection at that region, so I said, I'll bring the patient for a CBCT rather than a medical CT. So this is a screenshot of our cross-sectional imaging. You can actually see the upper left 2, 3, 4 being displaced. So this excludes that this is not a dentigerous cyst. If you think of a developing dentition, one of the key clues you need to use is it's surrounding the developing tooth or unerupted tooth. Clearly, it's not connected to any of the developing teeth. You have a crossly carious molar, and there is a large, well-defined radiolucency extending all the way to the alveolar crest with communication with the oral cavity. And I said, this is not a dentigerous cyst, and we all know that it's not very common to have a radicular cyst at the associated with the primary dentition. I said that it's not typical, it's not common to have a radicular cyst. So I asked them to do biopsy to see if this is something like a keratocyst or even an unicystic ameloblastoma, which has got more displacing potential. And interestingly, this turned out to be a radicular cyst associated with the carious upper left E. We do have other inflammatory cysts, less common. More commonly, we see recurrent pericoronitis associated with commonly with the lower third molars, where you see distal bone loss adjacent to the crown. Sometimes the bone loss can extend buccal or lingual, depending on how the pocket develops. But if the lesion becomes over 5 millimeter, becomes well-defined, corticated, then you're more likely to be dealing with a paradental cyst. This is another interesting entity. I have come across a few of them, and usually when they come in groups. Young children presenting to sort of any swelling with a sudden buccal swelling with sudden acute development of a facial swelling. And when you look at the panoramic radiograph, it's very subtle. You hardly see anything, or there may be a hint of some sort of furcation bone loss, or just a hint of radiolucency overlying the roots of a developing molar tooth. But on cross-sectional imaging, you can actually see there's a well-defined radiolucency sentinel buccal to the tooth. It's an inflammatory developmental cyst. Okay, this is the most common developmental cyst, dentigerous cyst, where it's very typical and more easy to identify when you see it classically attached to the cement-enamel junction of a tooth. However, when the lesions become large, it becomes more challenging. On the left-hand side, you can actually see that the unerupted lower right height has been displayed so mesially, and there's quite a lot of expansion. And this patient presented with an acute facial swelling. The reason for that is it's been infected. When you have an infected cyst, you lose the cortication, or you get like thick peripheral sclerosis. And you can also see periosteal bone reaction adjacent to the cyst. And it actually helps you to see the best surgical approach to get the tooth out and how minimally you can actually intervene the cyst. This is an interesting one. This was an incidental finding on a radiograph. I don't know how many of you could see. As I said, the lesions in the maxilla are not that obvious. Here, the right maxilla looks rather bizarre. You have almost seeing some sort of corticated lines, and you have a lot of superimposition of the zygomatic bone. So you don't really see a radiolucent lesion well. So got this patient back for a CBCT scan, and you can actually see a multilocular lesion occupying the most of the right maxillary sinus. Looking at the corticated margins, we can tell that it's odontogenic in origin, taking over the maxillary antral space. It's not within the antrum. And so I said the main differential diagnosis, given it was less expansile, I said most likely an odontogenic keratosis. So I've asked them to do biopsy. I think the first biopsy came back as inflammatory cyst, and then or an odontum, and I had to. So the pathologist contacted the radiology department, and I said that actually I don't think it is an inflammatory cyst. I really put my money on this being something like a keratosis. So another rebiopsy was done, which actually confirmed this was a keratocyst. Lateral periodontal cyst, as I said, it develops in between the roots, especially between the lower canine and premolars, or between the premolars. They start off as a small, well-defined corticated radiolucency, but the classic radiological feature to tell that it's not arising, it's not tooth-related, is you actually see the pedial space through the radiolucency. Okay, that differentiates that it's not arising from the radiolucency. However, a small keratosis and ameloblastoma, when it's developing, it can mimic a lateral periodontal cyst, and biopsy is the way forward for the diagnosis. So talking about the multilocular radiolucencies, I'm pretty sure there will be a lot of interest and discussion today on the odontogenic keratosis. I have to point out key features, what we use. They tend to be less expansile, and they displace the teeth very little. Resorption is also very uncommon. It's only large lesions tend to have very little resorption. But the lesions can behave different depending on where you see them. In mandible, they tend to be less expansile, whereas in maxilla, they could be quite expansile as well. So is an anterior mandible. And you can have interesting other mimickers, especially in young children. When you come across solitary bones, this can look like a keratosis. I'll share some cases. But if you come across multiple keratosis, you need to be thinking of Gulls-Goldin syndrome. I have to say, most of the keratosis are picked up as an incidental finding on radiographs, almost, because they do not present with clinical features of swelling. So you need to be beware, if almost like if there is nothing clinically and you're picking up these lesions, radiolucent lesions, then almost you're dealing with a keratosis. And this is a classic example where somebody didn't even get to know that there was much going on in the jaw. All they felt at one point is the occlusion on the right-hand side has become slightly altered over a period of time, and you can see the lower right 7 is slightly higher. So the patient was feeling that difference. So we did the panoramic radiograph. Panoramic radiograph is an interesting way of interpreting the findings, because you do have lot of ghost images which can mask some of the lesion. If you look at the right and left mandibles, you see these opaque shadows overlaying them, which can obscure some of the details. So when I present this to my juniors, where do you see a lesion? Almost everyone gets it right in terms of, oh, apical to the lower right side, I see it. But when I ask them, how big is the lesion? Most of them struggle to tell where exactly the lesion extends. And actually, if I draw the attention of the audience, actually this lesion extends all the way from the sigmoid notch to the lower right 6 distal region. It's taken up the entire ramus, sparing for the posterior border. So we did a cross-section imaging. PA views, I think I should say, when I was a student, we were doing it. We hardly do, except if it was done in the A&E for facial swelling or for trauma. We hardly do it for the assessment of any cystic lesions nowadays. You can actually see on the axial section of the cone beam, there has been very little expansion for the size of the lesion. That's very classic of a character cyst. This is another interesting lesion who presented to A&E who had difficulty opening the mouth, so the panoramic radiograph was taken. It's very subtle, but one of the striking features, if you look at the width of the ramus between the right and the left, it's quite different. If I draw your eyes closely, there is a large, well-defined radiolucent lesion, quite a lot of expansion, and you're seeing just a little bit of the inferior margin. It was seen in the main hospital because the patient presented with facial swelling. So the patient went in for a medical CT because they wanted to see if there is a large cyst or a tumor and if there is any connection to drain. And this was an infected odontogenic character cyst. This is another interesting example where it's a young person, it's a young patient with developing teeth, and you can see lots of displacement in the mandible. I think it's very obvious to all of us there is a well-defined radiolucency distal to the lower left 7. But in maxilla, you can actually convince yourself you don't see a huge radiolucent lesion, but there's a lot of displacement of teeth. And when you draw your eyes closely, yes, you're not seeing the normal bone there. You have multiple odontogenic characteristics, and this was a Gold-Collins syndrome patient. I want to touch upon the lesions mimicking cysts because it's very important how you arrive at the diagnosis in the best interest of the patient. The principles of displacement, I think the surgeon got this case to me because they said, oh, there's displacement bilateral. There are large multilocular radiolucent lesions with displacement of the 5. In fact, if you look, as I said, in maxilla, the air is the darkest. So if you see well-defined multilocular radiolucent lesions, then you're almost dealing with the maxillary sinus, because if anything has taken over the sinus, it becomes more opaque. The reason why it looks bizarre, because it's large, well-pneumatized sinus. Since there are displaced teeth, the antrum has actually pneumatized all the way to the alveolar crest. So this is an example of large maxillary sinuses with septations. This is an interesting one. This was taken for orthodontic assessment because obviously the 7 has not come through, and they had this unusual appearance of the right maxillary sinus. You can see that there is some sort of heterogeneous opacity and kind of a multilocular appearance. At that time I said, I think it's most likely maxillary sinus. But it needed clarification to see what they have to do next to the patient. Can they continue ahead with the orthodontics? So I did agree to do a cross-sectional imaging to confirm it itself, which actually confirms it's a small maxillary sinus compared to the left, and it's got internal septations which gave that bizarre appearance. And almost all of us will come across this Stephanes bone cavity. My experience, we do nothing about it. We don't do any further investigation. Now and then I get to hear from people, can you do a cone beam to confirm, MRI to do, or do you want to do a cyanogram? I always say, you know what, it's just a story. It's a classic developmental. If it's well-defined corticated below the level of the ID canal or partly superimposed on the ID canal, we do nothing about it. Just reassure the patient. Always is a good idea if the patient had any previous imaging, you can go back and look at it, which can reinforce the diagnosis. Okay. Looking at the differential, I mentioned keratosis commonly. I think we need to include the solitary bone cyst in one of the differential, especially when you're dealing with a young adolescent where you come across this well-defined corticated lesions classically extending in between the roots with little or no effect on teeth and really not much expansion. On imaging, you can't really differentiate a keratosis from a solitary bone cyst. This is why I said the systematic analysis actually helps, because the clinical picture adds value to your differential. In a young patient, adolescent, then you put your most likely diagnosis as a solitary cyst. It's very important you don't miss a keratosis. So we do, if we are absolutely certain this is going to be a solitary bone cyst, we just follow it on a panoramic radiograph. So follow it up in a year's time. If there is bone infill or changes, then we are happy with it. But if the lesion persists or if we feel that it's increasing, then the surgeons go in and do biopsy. And surgeons, I'm pretty sure they'll talk about it, which sometimes the biopsy in itself triggers the healing process. Not all solitary bone cysts are easy to diagnose. They're always challenging cases, especially when you see sort of loculated patterns. When you have septations, it sounds like some parts start healing, the other parts doesn't, which makes it more complex and makes it even more challenging to differentiate from solitary bone cysts. But the principle applies the same. It's the young age group, keep solitary bone cysts, monitor for healing. If it doesn't, then tread on the side of caution, go for biopsies and assess healing. This is a very interesting case I came across because this was referred for a cone beam CT scan for surgical planning of a question mark odontogenic keratosis. I said site prevalence is very important to narrow down your differential diagnosis. If you look at the features, it's got this sort of elongated pattern, expansion, minimal expansion, but a lesion extending from close to the sigmoid notch to the 7 region. It's got this scalloped margin. Clinically, there's no expansion, so you would think, yes, keratosis would be in your differential. But if you look with the contralateral side, you cannot actually see the ID canal because the keratosis is a slow-growing lesion, tends to displace. So with the keratosis, you actually see the outline of the ID canal better. In this particular case, I couldn't really see the outline of the ID canal. So, and it seems like it's centered within the ID canal space. So I put my differential, my top of my differential was a neural or a vascular lesion. So this is a cone beam CT picture to show that the mandibular foramen is quite widened on the left-hand side, and this lesion is happening within the ID canal space. The patient went in for an MRI scan. When we suspect could be a neural or vascular or should be differentiated as we go for MRI scan, the principles behind that is to try to identify the solid and the cystic components to help narrow down the differential. If it turns out to be a more fluid, avidly enhancing, then we'll be thinking of a vascular lesion. At that point, we refer the patient for CT angio. So this was an interesting case. The patient had a combination of solid cystic lesions, and this turned out to be a cystic schwannomatosis. This was another interesting case. This patient was referred by Maxfax. The patient was going in for the biopsy on the same day, and they wanted a quick surgical planning scan before that. So the patient had a CBCT to see the extent of the lesion. Again, the principle remains the same. I couldn't really see the ID canal, and I felt there was a lot of expansion more lingually and at the level where the mental foramen is, if you see on the reconstructed 3D reformatted plane. And I said, please don't do biopsy, send this patient for an urgent MRI to see if this is a vascular lesion before you touch it, because the safety zone is very important. It's not like whether we are absolutely right with our diagnosis or not. Common thing occurs common, but however, they do have atypical presentations, which we should be very careful. I think all of us with experience, we pick this up and say, when should we sit on the side of the caution to stop from a major adverse event happening. So this patient went in for an MRI scan. You can see on, you can see a lesion with low T2, T1 and high T2 with only like peripheral enhancement of the contrast. And this was in odontogenic keratosis. So it's not the question of whether we got it right or wrong. I think the principles remain the same, because if you are able to stop and complication, it's worth it. Okay, this patient then subsequently had the marsupialization. You can start seeing the bone in fill. You need to be very careful between the first and the second. When you see the refill, you'll be happy with it. But again, it's very important you monitor over a period of time, and you can actually see the cysts coming back more in the anterior segment. So the key learning points, what radiological diagnosis is only an anatomical interpretation. So you're using the key presence of findings. Is there a maxillary sinus? Is there a normal alveolar bone? Is there a normal structure which is meant to be there? If it's not there, then you think, could this be a variation? Could this be a pathology? If you're thinking of pathology, depending on what it is doing to the adjacent structures, is it behaving in a benign process, or is it behaving more aggressively on the bone and the adjacent teeth and the vital structures such as the ID canal or the maxillary sinus? Those are the findings which actually helps you to narrow down the differential diagnosis. We have to bear in mind it's not a tissue diagnosis, and we all know that, I'm pretty sure Selwyn will touch upon, even the tissue diagnosis, incision biopsy may not give you the entire answer. It's only towards the end we pick up what it is, and you always learn from it. So the key principles, always have a systematic approach, no matter what it is, how confident you are. Just see, is there any other feature which is not being very typical of it? Then think of, could it be something else? What could I think of as my differential? Or think of, is it a common presentation? Is it a typical feature of a common presentation? Or is it an atypical feature? Or is this a very uncommon lesion which is happening in the jaw? So that's how I broadly classify and go through what are the potential differential diagnoses. I think it's very important. I hate to give reports with a huge differential diagnosis. You have to think of what is the most likely, looking at the age factor and various other features. So I try to keep my differential very minimal, and most cases 1 or 2. If I'm certain, if it's a dentiture or cyst, I'm confident that I'll say it's most likely dentures, I don't give a differential. Whereas if I think that there are some atypical features, if I feel it's more pushed apart, if I feel it's not entirely centered around, then I'll bring the keratosis cyst into the differential diagnosis. Or if I see unusual features, I may include a unicystic ameloblastoma. So it's very important to keep your differential diagnosis minimum. And always you need to think about whether the clinical, radiological, histological features match with each other. There have been instances, including the cancer diagnosis, when we 3 don't agree, that means there's something unusual about the lesion. So it's very important to match all the 3 sort of entities. Think of cross-sectional imaging. I personally think it's very useful, but think of how good you use it. So careful reviewing of the images, especially when you're looking at keratosis, look for the tiny little cysts, especially when you see that it's a lingual to a root. Is that going to compromise the root? Is that going to increase the risk of reference? Those are the features you need to be actually using to aid in your surgical planning. I can't emphasize enough how particularly some of the complex cases or the atypical presentations, teamwork and communication comes in. We do have a multidisciplinary approach here. So this is how I would like to summarize my presentation. So I use the demographics, the history, the clinical features, then I think of the imaging features, then pass it on to the histopathologist, then we come to an absolute diagnosis. So there's a lot of interlinking between surgeon, radiologists, and pathologists in our approaches. Thank you.
Thank you, madam. That was an wonderful presentation. Lot of take-home points you have given. As you had said, a systematic approach in studying the radiograph, correlating with the patient's demography and clinical features, helps everyone to arrive at an appropriate radiological differential diagnosis. Thank you.
Thank you. Thank you, madam. Now I request Dr. Suresh to introduce the moderator for the next session.
Yes, Dr. Jensen. That was a beautiful lecture by Dr. Bhagyalakshmi. There are, of course, few questions from the participants, which we are going to discuss at the end of all the lectures in the panel discussion part. We'll take them up later. So let me introduce Professor Dr. Pratibha Ramani, who's an oral and maxillofacial pathologist who has completed her MDS in maxillofacial pathology from the Government Dental College, Chennai. She has also completed her DPNB from the National Board, and she is one of the very few persons to have completed PhD in oral pathology. Currently, she is holding the post of Professor and HOD of Department of Oral and Maxillofacial Pathology, Savita Dental College, Chennai. She has always excelled in her academic career and has won several awards like highest aggregate in perio and pedo in the final year BDS, gold medals, and Dr. R. Venkatraman endowment for highest aggregate, best outgoing in her BDS curriculum, Colgate Palmolive award for the highest aggregate in the BDS curriculum, overall highest aggregate in MDS. There are so many others which I'm not able to read out due to lack of time. She is the only oral pathologist to complete the DPNB in oral and maxillofacial pathology in Tamil Nadu. I think there are only 5 people in the whole of India. She has about 125 scientific publications so far, and she has co-authored and contributed a few chapters to some of the textbooks too. She is extremely interested in research projects now, and she has received grants from ICMR, DBT, etc. for such research projects. So now may I request Dr. Pratibha Ramani to take over and introduce Dr. Selvam to express his ideas on today's topic. Thank you.
Good evening, sir. Thank you so much, sir. It's indeed a proud feeling to hear from your own teacher telling about you. We are all just a part of Sailing Cloud, and we just hope to contribute for the patient as a whole. That's always been our aim, and we have been thought about it. And also, I would like to thank Dr. Jimson for giving this opportunity, and AOMSI for also giving me this opportunity. And now it's great to introduce our speaker for the day, Dr. Selvam Tavaraj. Dr. Selvam Tavaraj has been appointed at the King's College London and Guy's and St. Thomas NHS Foundation Trust in 2009, following specialist head and neck training in pathology. He's a part of the histopathology service for one of the largest head and neck cancer treatment centers in the United Kingdom. His research interests includes biomarkers in potentially malignant disorders and cancers, as well as in various aspects of human papilloma virus and other microbes in the head and neck region. He has co-authored and published more than 50 peer-reviewed articles and several book chapters. He has also advised on national guidelines for the management of head and neck cancer and is active in undergraduate teaching and postgraduate training. Welcome, Selvam, sir. We are eager to hear from you. Thank you. Thank you so much, Dr. Selvam. It was truly a wonderful lecture, and I think you spoke all our pathologists' mind today. that it's not always that, though histopathology is the gold standard for diagnosis, many times we have to accept the fact that we just miss it completely and put the surgeons on a fix as to when we are going to give it as a cyst and then it lands up as a tumor. Ultimately, they are the people who face the patients. So I think, as you truly put it, it's always a teamwork. I strongly believe in seeing patient and seeing a radiograph and then give my histopathological diagnosis, and the teamwork always helps. Thank you so much, one and all.
Pleasure.
Thank you, Dr. Selvam and Dr. Pradeepa. This did a wonderful presentation. Now, from the oral medicine perspective to the pathologist perspective to the surgeon's perspective. May I invite Dr. Suresh, who will moderate the next session on surgery, to introduce the first speaker. Over to you, Suresh.
Thank you, Dr. Jim. So, let me have the pleasure of inviting and introducing Dr. Kandasamy Ganesan to you. From the oral surgery, we have three excellent speakers who are lined up. The first one is going to be Dr. Kandasamy Ganesan from the UK, very fondly called as Candy by everyone. He has graduated from the Tamil Nadu Government Dental College and Hospital in the year 1998. I'm very proud to say we were batchmates and we passed out together. He used to work very hard and he had the goal of reaching the UK to specialize for his oral and maxillofacial surgical training, and today he is really successful. He became a consultant oral surgeon since September 2011 at Southern University Hospital, comes under NHS Trust, and also he works as a honorary senior lecturer at the University of Leeds. He has super specialized in certain topics like management of deeply impacted teeth, neonatal tongue tie release, and management of cysts of the maxillofacial skeleton. He is a reviewer for the International Journal of Oral and Maxillofacial Surgery, and he is an examiner for Royal College of Surgeons of England, Edinburgh, and Glasgow. He has several publications to his credit too. He has a commendable interest in the academics, and so he keeps organizing a national level oral surgery symposium annually in the UK. Many budding oral surgeons are benefited through this program and they improve the delivery care in oral surgery. We are really happy and proud to have you here, Dr. Kandasamy Ganesan. Everybody is waiting to hear you. Let's commence.
Hello, everyone. Thank you for the great opportunity for us to get involved in the educating via AOMSI. Thank you, President Veerabahu. Thank you, Jim. You've been a legend during this lockdown period. You've been conducting nearly now, probably you should be reaching close to hundreds now. Every week you bring your own valuable family time, personal time in educating the population. Thank you so much. And with Jim, Suresh has been doing excellent work, and yes, every opportunity switch on to listen to all of the specialists, in fact, all around the world. I do not know how you guys manage to get all the people around to do these lectures. Thank you for the wonderful opportunity, and thank you to all the secretaries of various other specialties, including Charlie ma'am. Okay, so my topic is about preventing complications, how we can identify using the imaging, how we can use our surgical skills to minimize the complication to give the best patient outcome is what I'm going to talk about. So what can go wrong? A lot of things can go wrong, especially in the mandible. The challenges with the mandible is not just looking into the cystic cavity, it's poor access into ramus, especially when it goes to the condyle and the coronoid process, with the septal walls broken down, leading to scallop margin, it is so difficult to access into these cavities. And the primary aim for the access is to take the cyst as an end block. One single bag is very important to to make sure we do not leave any specimen behind, and also allows the pathologist to have a really good overall look at it as well. Especially with the red line I marked, above that line, above the lingular region, is very difficult to access up in the condyle and coronoid process. Next thing is pathologically weakened mandible we are dealing with. On top of that, as a surgeon, you want to have a direct vision into the cystic area. As a result, you start to remove more bone. That weakens the bone further. Yes, you can probably prevent the fracture of the mandible by putting a prophylactic plating, but there is an adds and cost and time and a potential foreign body into the patient, which adds more complications for the patient. But it is a preventable complication. If you look at the CBCT of this particular patient, it is weakened all around, lingually, buccally, lower border, everywhere it is weakened. On top of that, there is a tooth in the middle. If you yank or pull without any care about the weakened bone, it will fracture. And that is very difficult to treat it because it's thinned out mandible for a large extent. The next thing is it's purely under the surgical hands. Yes, you can put a plate when you fracture the mandible, but when you have inferior alveolar nerve comes in your surgical way, you really have to treat it gently. If you don't, patient will result in having a numbness. Numbness is something you can live with. All the patients will end up having dysesthesia, which is unpleasant. You don't want to wish it on your own enemy, if you like. Devitalizing adjacent teeth, because teeth is important for the function. You want to leave them with some teeth to preserve so they can eat and enjoy their food. Devitalizing teeth is okay. You can get an endodontist to do a good root canal treatment, but taking teeth out is sometimes need to be considered with the patient in front of you, because you just don't want to take a virgin teeth out. But at times you have to take it because its pathology needs to be cleared. The next big thing I've seen over the last 10, 15 years is we as a surgeons, we take a large amount of bone that doesn't reform at all. That results in soft tissue collapse. So let me show you an example here. This guy turned up in my clinic with an OPT with a large radiolucent lesion. But if you look at the history, he has had surgery 10 years prior to this presentation. But unfortunately, in our healthcare system, anything beyond 10 years for a benign lesion or for non-medical legal reasons, they get erased because of the amount of memory they take into our computers and stuff. So we erase them. So we did not have any report about this patient. All the radiologists can say is, oh, it is, if you take the radiolucency as a focus point, it mixed with the radiopacity, which is alarmingly makes it look like a benign tumor there. But patient is completely asymptomatic. It's an incidental finding. Like any cystic lesion, most of the patients are asymptomatic patients. So essentially what I did is took the patient into theater, opened up. You can see a smooth bone all the way around. You can see the healthy bony margin, which I have not removed. It's already been removed. It's very smooth all the way around. All I could remove is the soft tissue out of this cavity. But again, the pathology confirmed there are no cystic fragments in this area. It was purely soft tissue. So we have to be mindful of the consequences of long-term results to the patient by not taking too much bone away. Now, bleeding is not a huge big problem in the mandible because you can always close the wound, literally allow them to tampen out unless there is a perforation in the bone through which it can leak out, cause hematomas in the submandibular sublingual region. But in the maxilla, it's a big problem. The next thing is displacement of fragments in the submandibular fossa. I know as a oral surgeon how forces applied onto the teeth sometimes can be pretty brutal, which is not an exaggeration. I have seen it. We can be very dab-handed, pushing the tooth, and especially in the cases like that, it is already on the lower border, close to the perforated lingual margin. If you yank and pull, it will displace into submandibular fossa. What it is a simple operation suddenly turns out to be a extra oral access to gain access into submandibular fossa to take it out. So you really have to have a modified way of taking these teeth out, not a conventional way, but I'll take you through how we do it. So the next thing is challenges with the maxillary cyst. The maxillary cyst, you have a path of least resistance. It goes directly into the maxillary sinus. As you know, you got the nose on the one side, orbit on one side, and then the posterior wall, then you have a danger territory. The problem here is not just bleeding. The bleeding, you can get oronasal fistula, oroantral fistula, and you can also, if you not scrape peeling the cystic lining off the chambers of the walls, you're bound to perforate into the adjacent cavity. It could be orbit, it could be nose, it could be posterior wall of the maxillary sinus. My biggest worry always is the supplying vessels can come from the adjacent major blood vessel. So it could be ethmoidal, which is the internal carotid artery. It could be maxillary artery, which is a branch of external carotid artery. So managing bleeding from external carotid artery is okay, but managing bleeding from internal carotid artery is a completely different ball game. So it is very difficult to manage the bleeding if you don't identify and cauterize as you go along. So knowing that these are the things you can go wrong, what is the evidence? We always go into the evidence, but if you look at the evidence of the odontogenic cyst, it is swarmed by volumes of articles about odontogenic keratocyst, and it is hardly you can just filter them out to try and look at generally how we can look into the complication. There are only a couple of articles came up to my search. One of them is a German article from German looking into the large extensive odontogenic cyst, which is more than 1.52 centimeter, which is what my database looks into it as well. And they are talking about decompressing following by enucleation gives a much better results without facing any complication. And there's another article where they summarize there are 12 fracture mandible following enucleation of cyst. So these are the two articles which jumps out talking about specific to odontogenic cyst surgical management without having to intervene a lot about keratocyst. So I'm not going to talk about keratocyst as Prof. GP Sir and Supriti is going to talk about keratocyst. So I'm going to skip and stick to just management of surgical aspect of cyst in general. So we know well there are only a couple of options. One is the enucleation, take it as a whole. I always say take it as a bag with a tooth in the middle rather than taking a piecemeal. With a piecemeal, you're bound to leave a fragment and that going to recur. Not only that, Dr. Selvam identified it's difficult to diagnose when you give them a piecemeal appearance as well. And the next option is what we used to call marsupialization. It is now going out of fashion because marsupialization leaves a large bony wall. It's taken away, suturing the cystic lining into the mucosa, then they start to decompress themselves. But doing so, you are bound to leave a large bony defect in that area. So therefore, the decompression came in the practice. So I'll take you through what are the few samples of each cases. So when it comes to enucleation, for the large one, almost always in this day and age, in the last 4 or 5 years, I use the endoscope to look into the cystic cavity. So let me take you through one by one. So this is a large dentigerous cyst in the left angle of the mandible with an unrestorable left lower 7. I always see these unrestorable teeth as a godsend because I can take them out, I can improve the access without having to take too much of bone away. Here, we got two challenges here. One, don't want to take too much of bone, which will result in a pathological fracture at the time or post-operatively. Second, you cannot use a conventional elevation method to take these teeth out. So you have to modify them. And also you have to think about taking the cystic lining in one go. So let me play the video as we go along. So I use the endoscope also to record the cases. So here, it's a very small access, very minimal buccal and lingual access, preserving the bone, what is given it to me. The way I look at it, the bone is patient, the tooth is mine. So I preserve the bone as much as possible. That is the external oblique ridge. If you break that, you know it is a buttress. By taking the buttress away, you're weakening the mandible. If the patient is not following your strict post-op instruction, it will fracture and you'd want to fix it again. So either you can avoid, by preserving the bone, you can avoid putting a plate on and also saving a lot of post-op complication to the patient. Also preserve the periosteum, which is surrounding that area, because I see as a beautiful sheath which is holding the fragments together. If you take a undisplaced fracture mandible, you don't treat them because you have a beautiful periosteal envelope surrounding the undisplaced fragment, holding the fragment together. So taking that principle, applying in the cystic cavity as an undisplaced fracture. So don't take too much of bone and just preserve what you have. So here I am using the roasted butter. I've taken the 7 out, removing the bone. And now the cystic cavity is very small. So the endoscope aids me to peel the cystic lining, monitor the supply, blood supply, so I don't lacerate the blood vessel, pull the blood vessel, causing numbness to the inferior alveolar nerve distribution area. Here also you have the lower wisdom tooth, which needs to be taken. And the way to take it, you can't use a conventional elevation methods, fulcrum on the bone, which will then cause a fracture. So the way to do it is a small occlusal prep straight into the pulpal chamber, and has to be parallel to the vertical axis of the tooth, and then put a straight Warwick James and luxate it. Bear in mind these teeth are pathologically pushed out of its position. So it is a constant resorptive process around the roots of the teeth, allowing the bone to be softer for the tooth to be moving away from the cystic chamber. So effectively, it is an easier tooth to take it out if we approach in full taken care. But I'll show you there is not always a fixed rule. There's going to be standard of deviation. So this essentially is how it's taken out. And then I realized the tooth is actually bigger than the cystic cavity. And then I have to take the cystic lining, separate it away, and then split the tooth, put that in horizontally, and take them as a 2 fragments, split them into 2 fragments, and take them one by one. Then, and the next thing comes in your way is using the endoscope. You can actually inspect the whole of the cavity to ensure you've removed the whole of the cystic lining. And here you can see a perforated lingual cortex with a thin periosteum separating the mylohyoid muscle. And the defect is absolutely intact, preserved, and there are no cystic lining. You can see the socket of the 7 in the 4 o'clock, 5 o'clock position. So the endoscope works in that way. So when the moment the endoscope goes in, you need to have guidance, but that is your guidance. And also have your own guidance to say which angle you're going in, so you are not confused. Sometimes when at the beginning of my journey, I was a little bit confused by the endoscopic vision inside the cystic chamber. So essentially, endoscope gives you a wonderful view. Here I'm showing another sample. Again, endoscope I use to record and go into the cystic chamber. It's a cystic cavity in the maxilla. It's coming from impacted upper 7 and 8 region. So here is showing an example of how to peel the cystic lining away, not scraping away. You use a DeBakey's forceps, non-toothed forceps, and you carefully peel the cystic lining away. As you carefully peeling the cystic lining away, you can see the feeder vessels. You can actually bust them, cauterize them before you take them away. So it gives you a direct view. And by taking them, peeling them away, it's a lot gentler to the surrounding tissue. Rather than scraping them away, you then bound to perforate the thinned out bone into the other cavities. Here I'm showing the whole cystic lining is being taken out with the impacted tooth. So take it as a whole is most important thing. And the next sample, next challenge we face here is not just taking the cystic lining off, taking these impacted teeth out of the cystic cavity. It's challenging. As I said, it's predictably easy if you plan it really well. And here I'm showing a sample in the maxillary cyst. Is a large dentigerous cyst in the left maxillary sinus with the tooth completely displaced out of its position into the posterior nasal cavity. and you can see the cystic expansion around the buttresses, and it's already thinned out. So I don't need to remove a lot of bone here. All I'm doing is cover look size a centimeter into the anterior wall of the maxillary sinus, then go into the cystic cavity to see the shimmering appearance of the cystic fluid, and then the tooth. And the next thing I do is exactly how I did it, is an occlusal prep straight into the pulp chamber using the rosette burr, and then you drill into that and use a straight Warwick James instrument or any straight instrument narrow enough to go into that cavity you prepped, and then use that to luxate it. It's simple as that. You don't need a forceps, you don't need to put a big elevation points. It just beautifully loosens out, and then you take the cystic lining with the tooth to prove it is attached to cementine enamel junction. It's fairly simple, straightforward when you can see it, when you can plan using the radiology. But there's always a standard deviation. Like I said before, this one, I thought it's going to be simple, straightforward flick. Let me show you the CT scan. It's a large dentigerous cyst in the left angle of the mandible. Fortunately, there were no teeth to remove. It's a dentulous area. You can see the tooth is at the lower border with the nerve wrapped around. Same risk, fracture mandible, displacement of the tooth, numbness, may need a prophylactic plating. All that can be simply nullified by approaching carefully by endoscopic approach. So here I am, applied the elevation point, then realize it shattered away. My principle of simple luxation did not work at all. Obviously, life teaches you lesson every single day, and this is one of them. So I had to go piece by piece, take them out in fragments. Here you can see the lower end of, it's literally at the lower bottom. You can see the ID bundle there. It's a distal root of the tooth. Mesial root has been already removed. So with the direct vision, ensure the endoscope is slightly away from the rotating bud. The moment the rotating bud touches the endoscope will shatter. That's 10,000 pounds gone, and you will be the most elated person because these are reusable. They are used multiple times. You don't want to damage it. This is how it keeps it cost effective. A small drill hole and a cryos elevator goes in with a direct vision, and the root comes out. So once the root comes out, you want to go back and see what is happening into the cystic cavity. You can see the distal socket, mesial root socket, and then the ID bundle there, inferior dental nerve. There's a bleeding coming from there. There's a bit of a muscle exposed. What it is, a small piece of fragment flipped over, fallen into the mesial socket. So all I have to do is put it back. That's the lower end of the masseter muscle. And then taken out completely to confirm with the chamber, with the use of endoscope, and then close it up. Then comes the biggest part. This is where, as a surgeon, you can play a role. You don't have any other equipment to come out of the problem. It's you and the nerve to manage it. So let me show you an example. It's a 14-year-old lad with a large cyst here, a large cyst in the maxilla as well. Again, it is being investigated for Golin-Gold syndrome. Here I am at the endoscope going into the cystic cavity. It's a well-preserved buccal and the lingual bone. You can see the buccal bone is well-preserved. Lingual bone is well-preserved. It's already thinned out. And then taking out the cyst in one bag. So as you peel out, and then I see feeder vessels into the cystic lining, identify that, cauterize that, section it, and take it out. So if I don't do that, I will drag the inferior alveolar nerve with the cystic lining all the way to the outside the cystic cavity. By then, it would have caused a stretch-induced nerve injury, which is very difficult to manage it, and the patient will end up having a numb lip all his life. So you have to be really careful. So I'm trying to say the cystic lining, well, preserved bone as a whole, and then the final moment, I see another feeder vessel, which again I cauterize and remove it. So it is important to identify these feeder vessels, especially in the mandible. Is more common than the maxilla, to look after the inferior alveolar nerve. It's another classic example. These feeder vessels can vary. between 1 millimeter to 2-3 millimeter. In this particular case, a large odontogenic keratosis removed. After removing, obviously I cauterized and removed it. You can see a pulsatile vessel branch, a large vessel branch. By the way, you can't spot this in a CT scan. As you enucleate them, you can see these feeder vessels. It was actually beautifully rhyming with the pulse oximeter beep in the anesthetic machine. And that was a nice thing to see for everybody, that we are able to see this well within the cystic chamber. So that is what the challenges you face with the enucleation and how we overcome. Not everything can be enucleated, mainly because the inaccessibility so weakened mandible, so you have to take that into account. So the next option is our decompression. Like I said before, it's a variation of marsupialization. You put a small hole and through which you put a small tube to balance the atmospheric pressure to the cystic chamber. So essentially that's what we're trying to do. So cases selection for inaccessible area, like I said, about that red line, I use the decompression. And also sometimes I want to make sure the thickness of the lingual and buccal cortical plate thickens up. So for me to go back for the second stage enucleation little earlier than before to enucleate it as a whole. So I want to gain some thickness in the mandible. So how does the science work? There are articles tracing backwards from 1997, clearly identifies PTHRP and interleukin alpha 1 synergistically work to control the resorption. So what it really shows is the Japanese article shows the decompression actually inhibits the interleukin 1 expression. Therefore, the progression gets limited. It starts to shrink away. It works with every single cyst as well. So what are the challenges we face? So this particular one, before decompression, you can see the multilocularity is being lost, now resulting in a scallop margin. Obviously, you had to do 2 biopsies to confirm it is not an multilocular ameloblastoma. The management will be completely different. It's proven to be. First one came as odontogenic epithelium, like Dr. Selvam said. Smaller samples are not really representative of the whole of the cystic cavity. So I have to go back, do it again, then confirm possible odontogenic keratosis. But as a surgeon, we saw a lot of keratin flakes inside. So that helps. So once we've done that, we decompress it, it beautifully bone deposits. The problem is the scallop margin starts to reform the follicle again and again. So you have to perforate these follicles together to rejoin them. So that was my biggest challenge with this particular case. I have to go back and reconnect the cavities into one huge chamber. You have to be mindful. So you have to take a serial of X-ray every 3 months or so. If they separate away, you have to break them back to connect into the tube again. It's not easy for the patient to have a tube in the mouth. They hate it. First 3-4 weeks, they absolutely hate it because in the mandible, the gravitation takes the food debris inside. They get infected. So difficult for them to manage it, but they learn to live with that. They learn to overcome that, and then they become master of looking after themselves. So it becomes easier for us as well. So I have to go back and replace the decompression tube, and the end result is this. Yes, we had to take a teeth out because of the odontogenic keratosis, but unfortunately, a year later, this patient recurred in the condyle. So again, we went back to remove that. This time, if you notice it, the anterior temporal crest never thinned out. So the coronoid process is actually thin, but it didn't thin out. It stayed as a thick bone. So we have to remove that to gain access into the condyle. Only when we use the coronoid solution, because it's very difficult to they control the flow of the coronoid solution in a bigger cavities that almost always burn the nerve and resulting in numbness. So I tend to use on a recurrent cases or a smaller cystic lesions, which is easier to manage. So this is a second year post-op, and the third year post-op, you can see as a small cavity that's being monitored. My feeling is this is a small soft tissue collapse there, and that's what stays as a radiolucency. It's not a bad result comparing to what she would have gone through if it were removed when it was called keratocystic odontogenic tumor. We were tending to resect them. There is no scar, well-preserved sensation. She has her own jaw and normal function as well, without any post-op complication. The second case, a young boy, it's a 24-25-year-old, very chatty, young, chirpy chap, large odontogenic keratosis. The problem here is it is already started to go through the roots of the teeth. That is how the keratosis behaves. They go through the path of least resistance along the medulla before they expand out, unlike other cysts. So that provides another additional challenge. We end up having to dentally destructive by taking the teeth out, but preserving the bone at least. So in this particular case, we were decompressing it, realized soon that it is decompressing really well from the ramus, but in the body, it is continuing to expand from here to the 6s. So we had to go back and remove the 6 and the 7 as well, and enucleate it through the socket, that small fragment of cystic lining. This is the 4 years post-op. You can again see a small soft tissue collapse into the region. And another sample of it, it's again a decompression, large odontogenic keratocyst into the ramus, decompressed, dentally destructive again. As I said, they go under the roots of the teeth. Every time I decompress, I'm very mindful of they can recur, and this one has got a 3 recurrence. So went back to enucleate them and treated with a carnite solution with the direct vision. This is a 2 years post-op with a beautiful bone infill in this area. From there to here, from this lesion to that lesion. Yes, dentally, it's been destructive. Unfortunately, at this point of time, I'm not unable to control being dentally destructive. Maybe in another 10, 15 years, I should be able to make a difference. It's another young boy, 24 years old, came in classic. Everybody bet on it. It's amyloblastoma. It is amyloblastoma unless proven otherwise. Taken a biopsy, removed these teeth out, put a compression tube, mainly because it was a cystic fluid. Like you would see a shimmering appearance of cholesterol crystals in the cystic lining. Sent the specimen out, came back as a odontogenic epithelium. And I was like very surprised, obviously having to go between the radiologist, pathologist. In that meantime, within the 6 weeks, he started to have a bony infill. So we decided to have a chat with the patient, continue with the same rather than going for more, sort of explorative surgery. And then you can see a 3D CT showing classical amyloblastoma-like expansion. But this is a 4-year post-op. He went back to remove the final lining off after the decompressed cystic lining. Then it came back as amyloblastoma. This is a 4 years post-op. So not all the amyloblastoma in this day and age need to have them resected. But increasingly, evidence coming up in our own experience, this is the 4th case where we just simply managed with the decompression and enucleation. In summary, you can form a flow chart. This is my flow chart. I'm not going to go into detail. I've already explained to you how I selected my cases. I'm very mindful of bone. I'm very mindful of the adjacent anatomical structure. I'm very mindful of not to exaggerate the surgery. My belief is keep it super simple principle to give the best outcome for the patient. So you can put a beautiful flow chart, you can justify your evidence-based approach, but then life is not always predictable. And I'll show you an example why it is not predictable. You can, in summary, basically, avoiding conventional fulcrum elevation point to the bone. I showed you how I did the occlusal prep to take the teeth out, and preserving the buttresses, very, very important to prevent fracture of the mandible, protecting the periosseal cuff, which stimulates a beautiful bone formation. So you allow the nature to take care rather than you being artificial. And minimal force, atraumatic, I say it again and again, no brutal force, just be gentle, use your fingers rather than arm and elbow. It's not orthopedics, it's gentle tissues. And most importantly, a post-op advice and pre-surgical planning. So all together, you get a good result. But then life is not always predictable. It is not fair. And I get this 14-year-old young boy, severely autistic spectrum, mom do the talking, he won't even look at my face, multi-locular radiolucency everywhere, classic girl in goals type of presentation. And the mom has already taken the child to 2 or 3 different specialists, all said he needs a decompression, may well fracture, we'll need an external fixation and stuff. There comes above and beyond, there is something in us something rules us, above us. Superpower, you may think it's your luck, you may think your fate, patient's fate, you can say it's God's grace. In my case, it definitely something worked, and I have to go as an osteoperiosteal flap to preserve the bone. And this is a 6 months post-op with a well-preserved sensation and a beautiful bone deposition. And we got away with it, I have to say. If I did anything wrong, I'm pretty sure I would have been crucified. But I justified my reasons, several opinions being taken, approached it in a careful way, and successfully came out on the other end. You can even see the teeth are now getting back to their original position. All he needs is, if he cooperates, an orthodontic brace and monitoring for long-term for recurrence. He's now been referred for Golden Gold syndrome. Now, let me also show you a few examples of post-op results before I sign off. And this is the case I showed you, where I specifically left that wisdom tooth there, mainly because it wasn't as a part of the cystic chamber. This I was able to see it with the endoscope, and then it is now come down to the lower level. It's only 16. And maybe in a year or two, that tooth will erupt into the mouth. You can already see a breakdown in the mucosa. The distal cusp is seen through in the edentulous area. So it's nearly there from all the way to the pterygopalatine fossa to your edentulous area. So essentially, few examples of post-op to show really good bony infill. So what is important is to first say, identify the high-risk cases. Can I do it? I need a good support from my pathologist, radiologist, my surgical colleagues, my endodontist. Plan them using the CT scan. We have sophisticated 3D scans. You must plan before you execute any treatment, and get an informed consent. The patients can see all these 3D scans. They know what they are signing up for. They need to know all the potential complication, and not just listing the complication. You must explain how each one of the complication can be prevented by your experience. In my case, I use my database as my support. I show them what my complication rates are. In the mandible, I've done about 70 mandibles. And my numbness case is only 5 numbness cases, no fracture mandible, no prophylactic plating either. And that actually reassured the patient for them to choose me as a surgeon. And then obviously equipment like endoscope helps you. Intraoperatively, equipment really matters. Minimal periosteal elevation, less force, take the tooth out, not the bone. And these are my simple mantra. And the post-op, you then hand over the care to the patient to look after the wound, soft diet, no contact sports for up to 4 to 6 weeks, for them to take some onus, some responsibility for the good job you've done to protect you, them coming back to you again with infections and fractured mandibles. With that all together, you get a good improved outcome. Thank you for the opportunity. And this is South End Beach, by the way. It doesn't look like that today. It's freezing cold, like 3 or 4 degrees. Thank you.
Thank you, Dr. Candy. Novel ideas, well executed and well presented. Thank you so much. And we should really appreciate your videographic documentation. They are wonderful. Thank you so much. And let me take the pleasure of introducing Professor Dr. George Paul to you, who's going to be the second speaker in maxillofacial surgery. Professor Dr. George Paul, he is the king oral and maxillofacial surgeon in the territory of Salem, Tamil Nadu. He had completed his MDS in oral and maxillofacial surgery from the Government Dental College, Trivandrum, Kerala. Surprisingly, after MDS, he has finished his LLB also, which is a degree of law. So he is a lawyer himself. So many oral surgeons and other specialists in dentistry approach him for legal opinions and ideas. He is practicing maxillofacial surgery at Salem for the past 35 years. He is a very versatile surgeon. He can operate any type of maxillofacial lesion. He is one of the earliest oral maxillofacial surgeons to start operating on oral cancer cases. He was associated with academics for quite some time and has trained many young oral surgeons. He is very confident and very strong in what he is doing. And so he continues to shine as the most popular oral and maxillofacial surgeon in and around Salem. He is recognized throughout the nation and he is an invited faculty in several national and international meetings. He has held the prestigious posts of General Secretary and President of Association of Oral and Maxillofacial Surgeons of India. Currently, he is the consultant oral and maxillofacial surgeon for many popular hospitals at Salem in Tamil Nadu. Sir, we are waiting to hear you, sir.
Right. You can see the presentation. I am technically slightly challenged. Is it okay? I'm not on presentation mode, right?
Fine, sir. Can you go to the presentation mode, sir?
Yeah.
Yes, sir.
Is it okay?
Yes, sir. Perfect.
Good morning, good afternoon, depending on which part of the country you are, which part of the world you are in. And well, my spectrum for today is limited to the treatment of odontogenic keratosis. Much has been said about the several cysts of the jaw. I think we had some excellent speakers who spoke on the histopathology, on the radiology, and even a significant part of the treatment. In fact, I had a video which I took away after seeing Candy's excellent video presentation. So basically what I'm going to do is to go through some of the issues which are unique to odontogenic keratosis. You know, it's an enigma. People don't know whether it's a cyst or a tumor, and the fact that we've had so many changes in its nomenclature is evidence that it continues to be an enigma. And I'm also going to give a perspective on how I do it, I mean, in addition to what is evidence-based and available in literature. So all of you have seen these lesions typically occurring in the jaws. I think the name KCOT or OKC clearly describes the lesion. It's lined by the K refers to its histopathology. It's cystic, it's odontogenic, and is either a tumor or a cyst. It can occur, as I said, in the mandible or in the maxilla, most often in the mandible. But let's just go through the historical aspect of it. I got it slightly wrong here. It was 2017, I think, when it became when it went back to being a keratocyst. So until 2005, I mean, that's about 2 decades after I finished my post-graduation, it was an odontogenic keratocyst. And in 2005, I think in recognizing that it had an enormous tendency to recur, and the pathology itself, which was described very nicely by Bhagyalakshmi, suggested that it was not typically a cyst. It got named as a keratocystic odontogenic tumor. And 2017, it was, I don't know, downgraded, upgraded, but went back to becoming an odontogenic keratocyst. Now, the change of nomenclature, as far as I'm concerned, has not changed the way I treat it. But I've heard apocryphal references to how people treated it more aggressively when it was a tumor and less aggressively when it was a cyst. I don't think that was really necessary. In this context, I need to mention one person, Paul Stollinger, who I have met on a few occasions, but mostly his whole life has been more or less dedicated to dealing with OKCs. So he was one of the people responsible for making it responsible for naming it as a tumor, and he was one of the first people to object to it going back to being a cyst, understanding the enormous amount of recurrence and the amount of depredation that it can cause in the or to the bone, teeth, and to the structures of the mouth. So Stollinger's favorite theory, which is not necessarily shared by all pathologists, is that these odontogenic keratosis arise from the basal cell of the oral mucosa that covers the cyst. I tend to believe it because most of my treatment is based on that philosophy, because I always de-roof it and remove the oral mucous membrane. I'll be showing you some pictures of what exactly I do. And I would like to think that I have a fairly lower amount of recurrence than what is reported in literature. So some of the salient features, just before we go into the treatment, is, as I said, it could be from the basal cells, it could be from the dental lamina, the rest cells, or from the tooth germ. It is both sporadic and syndromic. You could see it in isolation, you could see it as part of a syndrome. We've already gone through the fact that the PAT gene on chromosome 9 mutation, which is a tumor suppressor gene, is probably the reason for the lesion, and therefore much more the reason why we should probably call it a tumor, perhaps. And as I said earlier, mostly in the ramus of the mandible, and significantly, when you look at it clinically, I mean, people have talked about it radiologically as well as from the histopathological point of view, the expansion is invariably not seen, which means it spreads significantly through the cancellous bone, through the marrow. Now, intraoperatively, we see a very thin lining, which is a challenge by itself, and one of the reasons why you might leave behind a bit of the mucosa. It usually has a cystic fluid, or a very pathognomic feature is cheesy flake-like things, which to such an extent that sometimes I think I don't even need a histopathological confirmation before I do it. I mean, it's so pathognomic. And the cyst, as I said, it mostly, it doesn't expand until in the very late stages. So it spreads for a long time and is symptomless for the most part. And it's invariably radiographically associated with unerupted teeth. Literature says about 30 to 40% of the time it's associated with unerupted teeth. But in my personal experience, anecdotal, I see it much more often associated with unerupted teeth. So you can mistake it for a dentigerous cyst clinically, but I have, for some reason, either my pathologist is obsessed with giving me a diagnosis of OKC, or it's probably the truth. I see more OKCs than dentigerous cysts, really, when I see it in this situation. So why would the treatment of OKC be different from other cysts? It's obviously, one is it's aggressive, as several of the speakers before me have mentioned. The recurrence rate is very high, and the possibility that it is part of a syndrome and you need to look for other elements of the syndrome. This is an old reference, just to touch on some of the things. Up to the third year after, since we're dealing with the treatment, post-surgery, whatever surgery you are planning to do, up to 3 years, you really don't see the recurrence. And one of the reasons is because it is asymptomatic when it recurs. So, but after the 5th year, they say the amount of recurrence is significantly reduced. And it occurs as part of a syndrome. And if you remove it in one piece, it's just some of the things that we need to note. If you remove it in one piece, the chances, it's been said before, but I'm just reiterating, if it's removed in one piece, the chances of a recurrence is much less. If it is infected, obviously the lining is broken down and the possibility of leaving behind part of the cyst lining. If it is perforated for the same reason, you could leave behind part of the cyst lining. And one significant thing which I have noted as well is that if it is unilocular, however big it is, the recurrence is much lower than if it is multilocular and small. It obviously has to do something with the way you approach it and inaccessible areas in the cyst lining. So just a few systematic reviews. This is an old systematic review. Again, reiterating, one of the things I regret in the treatment of odontogenic keratosis is the number of resections I've done in the early years of my career. It helped me to learn surgery, but the poor patients were left with a lot of morbidity. And resections, obviously, when you remove the whole bone, unless it's syndromic, you don't have recurrence. A simple enucleation, as you would do in a cyst, has a very, very large rate of recurrence. And but what I use, the third one, a simple enucleation with adjunctive treatment. And what I do is enucleation, a curettage manually as well as with a burr, and use of a carnoid solution has probably the lowest amount of recurrence. More than almost 95% of them do not recur. And literature says that the same effect, I think Candy so evocatively demonstrated through his cases, that decompression is a great way of dealing with it. And I think decompression is a good way, but there is a lot of literature which refers to recurrence with decompression alone. So decompression followed by an enucleation gives it as good safety margin as enucleation with carnoid solution or other chemical or physical methods you might use to further enhance your clearance of the cyst lining. Say another reference, again, enucleation has the simple enucleation has the largest amount of recurrence, and resection has the lowest amount. And between that, you have enucleation and curettage, enucleation with carnoid solution, which is basically a chemical cautery. I'll tell you something about the carnoid solution. Enucleation and liquid nitrogen, and now cryosurgery or liquid nitrogen. Decompression and cystectomy also has a low recurrence rate. So I would really go with either enucleation, curettage, and carnoid solution, which gives me the best result. And decompression and cystectomy, apparently, from at least from we saw some of those good results that Candy was able to demonstrate, would give you a good result. I don't have access to liquid nitrogen or cryosurgery, so I don't do that. And the few cases of resection have worked out very well for me, but it's not something I would recommend. But enucleation alone is inadequate for an odontogenic keratocyst, biopsy-proven odontogenic keratocyst. So what's carnoid solution? You can Google it and find out what it is. I always keep forgetting in how many parts of ethanol, chloroform, glacial acetic acid, and ferric chloride is used. The more recent carnoid solution doesn't have chloroform because it's supposed to be carcinogenic. We still use chloroform. That depends upon the statutory limitations drawn up by your government or your guidelines, which are given to you from time to time. Spraying and there was something on using cold to destroy, basically cryoablation. But cryoablation has almost the same effect as carnoid solution, and carnoid solution is much more easily available, so that's what I use. So I just, and another thing that if there's one reason why I would bat for marsupialization or decompression followed by curettage or enucleation and curettage, it is because you can salvage the neurosensory deficiencies that are caused as a result of surgery can be reduced, and you might be able to save a few teeth. I think there's an endodontist speaking subsequently, so he would be horrified to know that me, like most of the other surgeons, remove all the teeth which are associated with the tumor. I know it's a very destructive process, but then I have had bad experiences whenever I've tried to not remove teeth. The few cases where I've had recurrences have always been, one of them has been when we have not removed teeth. This is another cryoablation technique. You put jelly, it goes to every part of the cyst, and you use a cryo probe to cool it to -80 or -100 degrees and cryo ablate the lining. Something that I have not done. I have little experience with that. The new treatment on the block is 5-fluorouracil, as well as some of the other chemotherapeutic agents, which seem to be slightly better than carnoid solution. And there's at least one paper which says that the neurosensory disturbances when you apply FFU is much less. So preservation of teeth, as I said, high recurrence rates. So you have to be mindful of daughter cysts and multilocular lesions. And I said resection, and I was talking about a segmental resection. And because I probably did a lot of cancer, I am very comfortable doing segmental resections, but it's not something that I would advise for a cyst in any case, cyst or a tumor, whatever you want to call it. The other is a peripheral osteectomy, which is also an ablative technique. I've used it on one case, which I'll show to you, but it's something that you can possibly avoid because, again, it is, I think, it's an overkill. So treatment options, we've gone through the whole bunch of them. I just want to emphasize on the last one: follow up, follow up, follow up. It's very, very important. One of the reasons why recurrences are not picked up is because we do not have a follow up, irrespective of what treatment sequence that you use and the modality that you use. And in defense of Carnoy solution, because that's what I have and that's what I use and that's what I would probably defend at this point of time, is that there are a lot of papers which say that from 0 to 25% is the sensory disturbance. I've had some sensory disturbance immediately post-operatively, but most of them resolve in 3 to 6 months. So I don't think Carnoy solution causes significant amount of neurosensory disturbance post-operatively. Even so, I try all my best to protect the inferior alveolar nerve. I don't use, I have used them, but I don't regularly wrap them in paraffin and avoid them. What I do is, if the nerve is in the field and I can see it, and if I can free it out, I move it around while I apply the Carnoy solution and try as far as possible for it not to touch the nerve. And that works for me. So maxillary odontogenic keratosis, if the cyst is not significant, it's not involving the maxillary sinus, I use a Carnoy solution. I mean, I do the regular thing that I would do for a mandible, that is curettage, enucleation, curettage, and Carnoy solution. But if it does involve the maxillary sinus, if it's completely into the maxillary sinus, I'm careful about using Carnoy solution because I probably the fear of the unknown. I don't know what exactly would happen, but I try to do as thorough clearance as possible, and then probably take an ENT surgeon's help to do a FES or do an nasal antrostomy by myself. So some of the cases where I've used enucleation, curettage, and Carnoy solution, you can see that it's the results are very good. There's a slight variation in what I do, and I'm just going to come to that in a couple of slides. So you can see the quality of bone is very good. You can always put an implant in, even if you've had to remove the teeth. It gives you much more faith in the fact that you have taken the disease away, and dental rehabilitation can proceed. Just a picture of a small maxillary lesion, odontogenic keratosis, biopsy proven. I pack it with a gauze, usually a BIP pack, a bismuth iodoform pack. I don't know, other people use other packing material. Bismuth iodoform pack remains for a longer period of time without getting infected. So that's the reason I use that. And same with the mandible, just some still pictures. I took a picture of an anterior region because it was easier to photograph it. My skills with technology and taking pictures are pretty bad. It explains why I don't record most of my cases. So that's bismuth iodoform pack being placed inside. But I always leave a small outlet. That's my decompression port. This is bismuth iodoform. And those of you who have access to it, please do use it because it's extremely good for all kind of cysts, all kind of areas you would like to pack and keep for a while. And you can see the gauze sticking out, and we would put an obturator with a small bunk to keep that patent, and that helps a lot. And I'll tell you why it helps a lot. Now, this is an example. I've removed the overlying mucosa, and we have removed the BIP pack, and probably 6th, 7th day, we take an impression and give the patient an obturator with a bunk which goes into the cyst, and slowly remove the size of the bunk that we have on it. So as the tissue heals, this works very well for me. I try not to close it primarily these days, and I'll tell you why. This is the way it looks. The obturator. This is almost healed lesion also with an obturator. It's not I think it's much better tolerated than decompression tube that you keep inside the mouth. 3 to 6 months, and bone forms pretty fast in these cases. The obturator with the bunk. Just some of the cases. This is just 6 months postoperatively. You can see that it's gone right up to the condyle, the coronoid process. All of them have been involved. What I've done is basically an enucleation, a curettage, carnoid solution, and given the patient an obturator. No neurosensory disturbance. I took care to ensure that the nerve was preserved. And the same, another patient with the typical feature, no cortical expansion. It's spreading through the cancellous bone. And of course, you saw Candy very expertly removing the tooth with a technique which I have never used, but I probably will use in the future. But I've always managed to remove the tooth otherwise without fracturing the bone. Yes. Now, this is a case I want to indicate in this case that this was actually someone I knew very well. She's actually a doctor. And I closed it primarily. I didn't leave it open with an obturator. And you can see that, well, this is immediately post-op. And this is 7 years, 6 years, 7 years post-operatively. The bone hasn't formed as well as we would like it to. This is something that I noticed. If you leave it open, that is, there is a decompression for reasons already explained by Candy, I think the bone forms and you get a much better bone on which you could put an implant or whatever it is for rehabilitation. The same situation here. I closed it primarily without an obturator, and this is what we had 7 years later, 7, 8 years later. So you can see that the bone formation is not significant if you don't decompress. And the treatment doesn't change when it is when there are multiple lesions, as in syndromic situation, which Sukhpreet is going to talk about. So I'm not just have a couple of slides on them. This boy typically had all the features of Golden-Gott's syndrome. And you see the multiple cysts in the maxilla, mandible, different places. And one of the things and of course, the bifid rib, you can see the bifid rib in the chest x-ray. Another thing that I've often noticed is, this is a patient I'd seen some years before I took this picture. And at that time, they had multiple small cysts. And sometimes they come together and coalesce as one big cystic lesion. And this is actually multiple cysts. The treatment for me is the same as I do with the others. And I think when we hear Sukhpreet, if he has got any other ideas for syndromic cysts, I would like to listen to that. This is another case of Golden-Gott's. Again, we did the treatment, standard treatment, removed each of those cysts separately. The one on the patient's left side, which is on the coronoid process. I don't know if this can be seen. This was removed by doing a coronoidectomy. We removed this as well. And of course, this an enucleation, curettage, and carnoid solution was used for this. And you can see this several years later. There is no evidence of any recurrence, at least it seems to be, until you look a little close and you can see the small thing. And so we're keeping this patient on surveillance right now to see if this is growing bigger, but it may not, it may just be bone lost, which is not formed. It's not growing bigger. If I remember, this was taken about a year ago. So it seems to be okay that way. But we need to keep surveillance, especially for the syndromic patients. And finally, aggressive approaches like peripheral resections, which I talked about, and segmental resections, which are something that I don't do now unless absolutely necessitated. I did one recently. I'm going to show you that picture. But okay, this is I did a peripheral rim resection only because it was a young person and I thought child has good osteogenic potential, and left a very small rim of bone below, and the bone formed. And you can see from the deciduous teeth, it's just 6 months and so much of bone has formed. I think this tells you that in young people with loss of a lot of osteogenic potential, you can play around a lot. I think the autistic child that Candy described also had the benefit of osteogenic potential, if you ask me. And this is a resection which I did with great, she looks perfectly all right, but she had an extremely large lesion which went right into the infratemporal space. And you can see from the CT scans, both lingually as well as from the outside, that there's hardly any condyle left and it's in multiple small pockets. And this was a patient I had already operated on earlier, and it's a recurrence. And I thought the only way out was to actually do a resection. I did a resection. I don't do microvascular flaps, so I can only do what I have. I reconstructed with condylar plate, and this is about 5 years maybe post-operatively. She's doing very well, and she looks perfectly okay. So in summary, and I mean, if you're going to get good results, it's okay. And in summary, just going back, KCOT is now OKC for those who didn't know, but I don't think the treatment has changed. Recurrence is the one big problem with OKC, and the teeth associated OKC, I would rather extract them and go for some kind of rehabilitation than keep them there, because I've burned my fingers too many times with recurrences. Enucleation alone is not enough, and you need to supplement it with physical or a chemical adjuvant. It could be cryotherapy, it could be FFU, it could be carnoid solution. What I use is carnoid solution. I have a very poor population which doesn't have much paying capacity. And always remember, it may be associated with a syndrome. And resection and reconstruction, though both of them look quite good, it's not an option that you should routinely follow. One other thing I wanted to mention is, it's a good idea to do decompression, but always follow it up with an enucleation and or curettage, whatever it is. But if you don't do that, I think the recurrences are much more. On a Sunday, I would normally be in my cottage in ERCOT. It's a lovely place. Today, because we don't have a good connectivity there because of the rains and trees falling, etc., I had to remain back in Salem and interact with you. It was a great opportunity. My email ID, in case you want to get in touch with me. Thank you very much.
Thank you very much, sir. Thank you for your time with us. You skipped the ERCOT trip today for us. Thank you very much, sir. And there is a lot of appreciation from the chat panel and question and answers. It was very informative, right? Starting from the nomenclature to the management. It was very informative. Thank you so much, sir. So I'll take the privilege of inviting the third speaker from oral maxillofacial surgery, Dr. Sukhpreet Singh Dub. He is a dually qualified surgeon and dentist.
1 second. What am I supposed to do with myself? I can still see myself. How do I get myself off? Okay, stop video, right?
Yes, sir. Stop sharing. That's all. Yes, sir. So Dr. Sukhpreet is a dually qualified surgeon and dentist who lives in the UK. He is a consultant in facial surgery today. He is a very great academician and has about 50 scientific publications already in the journals. He has given several scientific presentations in various platforms, nationally and internationally. He has been awarded more than 20 prizes for the international research and academic activities. He was also the UK ambassador for the White House and the United Nations. With this small introduction, I would like to call upon Dr. Sukhpreet Singh for the presentation. Over to you, Dr. Singh.
Thank you so much for such a very kind introduction. As much as I would like to take the pleasure of being able to say I'm a consultant, I'm still a very humble trainee at this stage. However, I first of all wanted to thank the association, Mr. Ganesan, and all of the panelists for letting me share this platform with you. This is a fantastic association. What a fantastic conference we have today. I'm also delighted to see that we have over 500 participants from all over the world who are constantly engaging with the wonderful speakers that we've had. And that really is fantastic. So thank you all for having me. And it's so wonderful to see so many excellent trainees, participants, consultants, professors from all around the world with this excellent association. Are you able to view my presentation okay?
Yes, Dr. Singh, we are able to see your slides, yes.
Fantastic.
Go ahead. Yeah.
I'm going to give an overview of Gorlin-Goltz syndrome, and I hope that we can also engage with the discussion at the end. It'd be wonderful to hear everyone else's experiences. So I always feel it's very important to start with just the history of where these eponymous syndromes come from, and very much Gorlin and Goltz. This condition was actually first described in 1894 by Jarisch, but it was these American colleagues of ours, the oral pathologist and geneticist Robert Gorlin, who co-authored their first paper with his colleague, the dermatologist Robert Goltz, who in 1960 published the seminal paper of Gorlin-Goltz syndrome. They called it the multiple nevoid basal cell epithelioma and published this in the New England Journal of Medicine. Back then, they described it as being a triad of multiple basal cell carcinomas, keratocysts within the jaw, and skeletal abnormalities. But as we've gone on to hear, actually this is a very wide-ranging spectrum, which is very much a syndrome, and I'll go on to talk about some of the variations and presentations that it has. Nomenclature is very important, and Gorlin-Goltz has been associated with and called multiple different things in the past since it was first described. This includes nevoid basal cell carcinoma syndrome, basal cell nevus carcinoma syndrome. There's all sorts of names that have been associated with Gorlin-Goltz. And the reason I want to highlight this is, although this is an emerging topic, it's very important to recognize the spectrum that Gorlin-Goltz sits on. And in fact, in 10% of patients, basal cell carcinomas aren't even a feature within the spectrum and presentation of Gorlin-Goltz. So with that in mind, a loose definition to bear in mind with Gorlin-Goltz is that it is an autosomal dominant familial cancer, which is characterized by the mutations in the patch gene, which sits in chromosome 9q. And really just very briefly about the pathology. This is a tumor suppressor gene, which involves the sonic hedgehog cell signaling pathway. And when that is disrupted, that is the reason why we get the basal cell carcinomas, the odontogenic keratocysts, and all of the other various deformities that follow. And these can include, but are certainly not limited to, basal cell carcinomas, odontogenic keratocysts, but also skeletal abnormalities, ophthalmic and neurological abnormalities, amongst others. And I will talk about these in more detail. The diagnosis, certainly here in the UK, is very well defined, and very importantly, this is a clinical diagnosis, and clinicians and patients alike should be aware that we follow two major criteria to give a diagnosis of Gorlin-Goltz, or one major criteria with two minor criteria. And these major criteria include two basal cell carcinomas, or at least one that is diagnosed before the age of 20. A histologically proven odontogenic keratocyst, but as we've heard from our other eminent speakers, often these are pathognomonic at the time of surgery, which I'll very briefly touch upon. At least 3 or more palmar or plantar pits, and I'll demonstrate some cases of this later. Ectopic calcifications of the cerebral falx, bifid fused or splayed ribs, and of course, what cannot be ignored is a family history of having basal cell carcinomas. And so the reason for putting these up, that 2 of these will satisfy having a diagnosis of Gorlin-Goltz, and really in the presentation of the patients that we see, this is very ubiquitous, and it's not at all uncommon to see patients with any one of these presentations. So it's always very, very important to bear in mind, does a patient sitting in front of you have Gorlin-Goltz? And the palmar and plantar pits is a very common presentation, and it's very easy to clinically examine in the clinical environment. The minor criteria are really widespread, and I won't spend, purely for the interest of time, I won't spend too much time going into these, but your cleft lip and palate patient could, although that's their primary presentation, could well in fact have Gorlin-Goltz syndrome. medulloblastoma is very, very often ignored and not thought about in our pediatric patients. And again, I'll go on to expand about this. Some of the skeletal abnormalities include synaldactyl, but also pectus deformities. And also ophthalmic abnormalities include cataracts, coloblomas, and microphthalmias. Of course, the patch mutation, but as I mentioned, certainly in my experience here in the UK, we very much limit genetic testing as this is a clinical diagnosis. Given the huge spectrum that we have in the presentation of Gall and Galt's, not only is it important to have Gall and Galt's in the back of our minds and to consider this as a diagnosis, but there are various differential diagnoses that come with this. And I'll very briefly talk about some of the syndromes that can come with this. Bayes-X syndrome, for example, is characterized by hyperkeratotic lesions that can occur anywhere from the nose, the palms, and the soles, and they're very often associated with malignancies of the aerodigestive tract. Rombo syndrome is a very rare disorder which is characterized by milia, and 30% of Gall and Galt's patients have milia, but also telangiectasias, peripheral vasodilation, and cyanosis. So these are some of the syndromes that can be either be mistaken for or just to be aware of, because they do also have their own important ramifications. And so moving on from the brief history and the diagnoses, how these patients often present, really the cardinal symptoms and signs include basal cell carcinomas, odontogenic keratocysts, and palmar and plantar pits. And the way that I think about these is what is readily available to me when the patient is in front of me within clinic. I'm sure that basal cell carcinomas are readily recognizable to all of us. But as I've mentioned, having at least 2 of these, or at least 1 before the age of 20. The highest incidence seems to be between the ages of puberty and the age of 35, but there are pediatric case reports that demonstrate patients having basal cell carcinomas. The number, the size, and the shape is very much multiform, and patients may have either singular or multiple basal cell carcinomas, and these sizes can range from being just 1 millimeter all the way up to 10 millimeters. And their appearance can be as ulcerating plaques or as the very typical and characteristic form of basal cell carcinomas, as I'm sure that we know. This is the association of oral and maxillofacial surgery, and we do love everything associated with the face, but don't forget that those 2 basal cell carcinomas do not necessarily have to be on the face. Even they don't have to be on the traditional sun-exposed parts of the skin. So a thorough clinical examination, if you are suspecting this syndrome, is really a must. Speaking of palmar and plantar pits, there are various quotes within the literature, but up to 70% of patients and up to 50% of patients have palmar and plantar pits respectively. And again, these can vary in their presentation, being just a few millimeters in size and in depth. And they do increase as the age of the patient goes. Now, just to speak a little bit more and things that I found useful in clinic, their appearance is most often visible by asking the patient to put their hands under warm water for a few minutes, and these make the pits much more visible. In Caucasian patients, they tend to have a red base, whereas in other patients, they have a much darker pit to them. From a pathological point of view, they are well circumscribed hyperkeratotic lesions that have a basal cell hyperplasia. And they're readily identifiable, and they form one of the major criteria for Gall and Galt's. And lastly, just one of the cardinal symptoms is the odontogenic keratocyst, and as Professor George and our other speakers have very rightly stated, these have gone through various nomenclature changes, but essentially they are recurrent multiple jaw tumors. they can occur in as many as 90% of patients, and as age proceeds, they become much more dominant. They typically occur more often within the mandible, and most often at the angle, but also what we as surgeons would call the parasymphysis. And so this is the area between the incisor and the canines of the teeth, but really throughout the mandible, they are a feature. They do occur within the maxilla, but they do tend to be much more aggressive when they make a feature, and actually their treatment can become a little bit more difficult. From a pathology point of view, we can split our odontogenic keratocysts into parakeratotic, orthokeratotic, and then really very rarely mixed lesions. At the time of surgery, when enucleating these cysts, they have a stratified squamous epithelium, and the vast majority tend to be the orthokeratotic form. At the time of surgery, it's really, really pathognomonic. It's very, very obvious when you're dealing with an odontogenic keratocyst. The cavity is often filled with a thick keratinous material, often a straw-colored fluid. And when you strike oil and are enucleating these cysts, it's very typical to see that keratin coming out. This does, of course, make diagnosis interesting, because with odontogenic keratocysts, with them being such an important and cardinal feature, actually most cysts, certainly in my experience, tend to be incidental findings. So the patient presents either with a generalized ache, or they're having pain in a particular tooth, and on taking a radiograph, suddenly we find the incidental finding of cysts everywhere within the mandible or even the maxilla. So the message really is to just constantly be vigilant, to be aware, and to do screening, so with periapicals, but also with OPGs. With the formation of odontogenic keratocysts, they often start life as spherical or oval bone lesions, and are very well defined with osteosclerotic rims, but their presentation is not too dissimilar from ameloblastomas. So again, just something important to be aware of. The all-important management. So as I mentioned, certainly here in the UK, and I'm sure the perspective is the same from my colleagues, is this is a clinical diagnosis. But there are scenarios where genetic testing is important to look for the patch gene, and that's where the clinical diagnostic criteria isn't so clear, and they don't fulfill, but you still have a strong inclination that the patient may be suffering from Gall-Colt syndrome. With family members, with this being an autosomal dominant gene and being familial in nature, again, testing family members can be important, and in certain situations, prenatal testing if there's unknown familial mutations. I'm sure we're very well aware of the variations in treating basal cell carcinomas, and so much of this can be dependent on what facilities are available. So, surgical excision, curettage and cryosurgery, even doing Mohs surgery. But we are now seeing these non-surgical variations of treatment, such as photodynamic therapy, and really the cutting edge, as I've mentioned, that the pathology with Gall-Colts is an abnormality in Sonic the Hedgehog cell signaling, and we now have drugs that specifically target this and switch this gene back off. And in the right patients, this can avoid surgery, this can avoid more invasive forms of treatment. But really, the bread and butter of treating basal cell carcinomas still tends to be surgical excision, laser therapy, and cryotherapy. With odontogenic keratocysts, we heard a very excellent summary from Professor George. And so again, this is very much case by case, depending on the age, size, and the location of these lesions. Regular enucleation, as and by itself, has a very high recurrence, as we've heard, and really this is because of satellite microtumors, and it really isn't good enough to just do enucleation by itself. I'm aware that there are practitioners in our audience who are not surgeons. And so essentially doing an enucleation is simply removing the cyst that you see in front of you, taking the lining away, but not really doing anything else. So this means that you're not decompressing the cyst, which is opening up its contents and either suctioning or vacuuming away all of the keratin that sits by. Not using any adjuncts such as carnoids or cryotherapy. And this is where once you've enucleated the cyst, once you've removed the lining and the cyst contents, we cannot guarantee as surgeons and as practitioners that there are either no remnants of the lining of the cyst within the bony cavity, or in fact that there aren't any microsatellite tumors. And even leaving a small portion of this cyst behind, then you will have a very high recurrence. And that is where really, as a practitioner, you use variations of adjuncts. So this can be carnoid solution, which, although it is toxic in nature as a solution, works really beautifully in trying to destroy and remove any remnants that remain within your bony cavity. There are situations where this is difficult to use because in the maxilla, this can be very necrotic to the delicate tissues that are there, such as the nasal passages. And that is why there are variations in using cryotherapy. And all of these adjuncts alongside decompression greatly reduce the recurrence that is not achieved by just simply doing a regular enucleation. I open this up to the audience as well as our panelists of whether we should be going further and doing partial resections, which is certainly much more invasive. However, it certainly does reduce the recurrence rate much more significantly. And in a patient who's having several operations and several invasive treatments, there perhaps is a role for having partial resections. And lastly, with a medulloblastoma, this is a pediatric presentation, which is often missed. And this is an opportunity for diagnosis at an early stage of life. So this is a malignant tumor of the posterior cranial fossa and is a variation in the presentation in patients who have got Gall-and-Gault syndrome, and typically affects pediatric patients at 7 to 8 years, but in our syndrome occurs before the age of 3. The presentation is typically headaches, nausea, vomiting, really very non-specific signs, especially in children. 10% of all medulloblastomas are suspected to have Gall-and-Gault syndrome, and they are treated aggressively with chemotherapy, but with excellent prognoses and excellent outcomes. And this is an opportunity to reach further into the history of the patient and see if they have any other presentations that could then fit in with Gall-and-Gault. As we've heard from our speakers, follow-up, follow-up, follow-up. And having an assiduous history is so important in all of our patients. And this is my whistle-stop tour of Gall-and-Gault syndrome and just the variations that we have and my experience here in the UK as a trainee and as a registrar. I want to thank everyone for taking the time to have a listen. Thank you so much to this excellent association for inviting me as a registrar and as a trainee to present to you. Thank you very much to all of my fellow colleagues and panelists for your mentorship. And I leave my Twitter details as well as the association. If I can be of any help to anyone listening, I'm more than happy. And I'm sure that we all agree that we're constantly learning. So it's such a privilege and a pleasure to present, but also to learn from all of you. Thank you all so very much.
Thank you so much, Dr. Sukhpreet Singh. And in our academic curriculum, we only read the headings. Like Gall-and-Gault syndrome is familiar to everyone, but there is so much to study in the particular topic is something new. So you enlightened us more and more details regarding Gall-and-Gault. Thank you very much for the presentation. It was highly informative. Thank you. And
Thank you.
Dr. Jimson, can you take over for the next announcement?
Dr. Suresh, chairing the session on oral surgery. Now, it's my pleasure to introduce the next chairperson, Dr. Kavita, on the session of endodontics. She completed her MDS in 1998 from the Tamil Nadu Government Dental College, and she is currently the professor and head of the department in the same institution, the Department of Conservative Industry and Endodontics. She is a editor-in-chief in the Journal of Operative Dentistry and Endodontics, and he's the Vice President of the Indian Association of Conservative Dentistry and Endodontics. He has been the member of the Board of Studies of the Tamil Nadu Dr. MGR Medical University for the past as well as the current Board of Studies as well. And she has around 60 publications in international and national journals, and she has lectured around 40 national and international presentations. Over to you, Madam Dr. Kavita. You're muted. You're muted.
Thank you, sir. I'm just introducing Dr. Mittal Patel. He is a consultant and honorary senior clinical lecturer in restorative dentistry at Royal London Dental Hospital and Queen Mary University of London. He was awarded his bachelor degree in dental science in 2002 and in dental surgery in 2005. Following a series of hospital posts in restorative dentistry and oral and maxillofacial surgery, he was awarded membership to the Faculty of Dental Surgery at Royal College of Surgeons of England. He then undertook a 5 years of accredited specialist training in restorative dentistry at the University of Leeds. He completed his master's in restorative dentistry, was awarded with distinction. In 2012, he passed the Intercollegiate Specialty Fellowship examination held jointly by 4 Royal Colleges of Surgeons in UK. He is a GDC registered specialist in restorative dentistry, prosthodontics, periodontology, and endodontics. He is a fellow of both Royal College of Surgeons of England and Edinburgh. He is currently Deputy Chair of the Advisory Board and an examiner for the Diploma in Implant Dentistry examination, Royal College of Surgeons, Edinburgh. Dr. Patel sir is a fellow and recognized speaker for the International Team for Implantology. Sir, over to you, Dr. Patel. Yes.
Okay, thank you. Thank you very much for the very, very kind introduction. Thank you to the organizing committee and the association for inviting me as well. And a special thank you to my friend, Dr. Ganesan, who I call Candy, for inviting me to this international platform. Candy has been running the South End Oral Surgery Symposium for a few years now, and it's been very successful. And right from the first symposium, he invited me to speak and on various topics around restorative dentistry. And I always felt a little bit out of place as a restorative dentist coming to an oral surgery symposium to talk. But it's always been very interesting how actually there is a lot of overlap, and this kind of cross-specialty thinking can really give a lot of food for thought when planning cases and treating our patients and trying to deliver the best for our patients. So with that in mind, it's great to see a huge number of participants this morning, this afternoon, depending on where you are. And I would like to take you on a journey looking at what the role of endodontics might be in the management of cystic lesion, and hopefully stimulate some food for thought. So thank you, everyone, and hope this is interesting for you. So the aim of my presentation will essentially be to try and answer some of these questions. Can endodontics alone treat cystic lesions? When should we undertake endodontic treatment, RCT, root canal treatment? What is the role of microsurgical endodontics? So as endodontists, we also undertake surgical removal of apical pathology or cystic lesions. When should we be taking a microsurgical approach in management of cysts? And then what are the health and cost implications of undertaking endodontics, orthograde endodontics versus a surgical approach? So, you know, lots of different cysts have been presented, lots of different cysts have been described, and so many are out there. And the question is, how many of these can an endodontist really treat or contribute to? And just as a sort of reminder, I'm sure I don't need to tell anyone this, an endodontic treatment is the treatment of an infected pulp of a tooth, which results in elimination of infection. So if we think about this, that endodontic treatment treats an infected pulp. Well, all of these cysts are not associated with an infected pulp of a tooth, so they're not going to be able to be treated by an endodontist. Similarly, the residual cyst is not truly associated with a infected pulp. So the only cyst that we're really talking about is a radicular cyst, which has a direct relationship with a tooth and an infected pulp. So if we think about a radicular cyst, it develops as a sequel to apical periodontitis, which is a necrotic tooth resulting in inflammation and infection of the periapical tissues around the tooth, and it must have a persistent bacterial stimulus from the necrotic tooth for the lesion to develop. Interestingly, it's the most common of all cysts in the head and neck region. It is maybe not the most complex and the most challenging to manage, but it is the most common. And because it's the most common, many, many patients present with it. And this is what we manage mostly on an everyday basis, at least from an endodontic point of view. It is often asymptomatic unless it becomes infected, a secondary infection. And usually it is only noted as an incidental finding because it's slowly growing away to be essentially to become a cyst. And then at some point it potentially perforates a cortical plate, and then you develop as a swelling or something like this. So it's either an incidental finding or some sort of swelling that develops. And by that time, the lesion is reasonably established and in place. So the patient is presented like this. Obviously, has had some endodontic treatment previously done. The quality is obviously questionable, but there is a large radiolucency. And when I look at this in the clinic, I can take all the clinical signs and symptoms and the plain film radiograph. And the question I ask is this a radicular cyst? Can I make that diagnosis just by looking at this radiograph? Then the next question is, which tooth or which teeth is it coming from? Is it coming from the upper left central incisor? Is it coming from the upper left lateral incisor? Is it coming from both? Will orthograde endodontic treatment work? Is that enough? Is this going to need a surgical approach? Should it be both? Should it be just one? And these questions are the kind of questions that we need to answer every day when we're on the clinic, when we're seeing lesions like this, wherever they are in the mouth. So if we try to answer some of these questions, is this a radicular cyst? Well, you can't tell clinically or radiographically. It can only be confirmed from histology, which we've already established through the fantastic lectures this morning. It's well circumscribed, well-defined radiolucent area, so it is in keeping with a potential cystic lesion, but a periapical granuloma could have a similar finding as well. Cysts are bound by a thin radiopaque line, and this is something you might look for. But in reality, just radiograph alone cannot confirm whether you're dealing with a cyst or not. If we look at the literature, there has been some papers which start talking about either volume or diameter of the radiolucency that you're dealing with, and to indicate whether it is a cyst or not. Problem is with plain films, you're only looking at it in in 2 dimension, and the lesion could be much, much larger in the 3rd dimension. And if we are going to follow this literature, then we may be looking at something smaller on a plain film, but might be much larger and could be a cyst. The question is, does it really matter? Does it really matter whether you're dealing with a periapical granuloma or a cyst? And maybe depending on what our treatment strategy is, maybe it doesn't really matter. When we think about which teeth is it coming from, you know, often we see these radiographs and the lesion will span over the apices of several teeth. And it is important to try and work out which teeth are the contributing teeth and then manage those appropriately. And if none of the teeth are contributing, then we've got to make sure we don't do the reverse, where we undertake treatment that was not necessary, but was just almost like a guess, or just because the radiolucency is there, where we should undertake endodontic treatment, and assuming that it may be involved. So you ask yourself, well, the cone beam CT scan helped me identify what teeth are causing the cyst. Well, not really. You know, the cone beam CT scan will tell us what we're dealing with in the third dimension. And again, if we go back to size, we might say, well, okay, this is definitely looking like a cyst, but it certainly doesn't tell me, if this is a true ridiculous cyst, which tooth the lesion is coming from. So even if I now have this information in the third dimension, has it really changed my treatment plan? Am I still going to do endodontics first, or am I still going to go for a surgical approach? And if we look at, so in my opinion, the CBCT does not really help us identify which tooth is contributing to the lesion. And if we look at the European Society guidelines that we follow when we determine quality of endodontic outcomes, it clearly states that the cone beam CT scan should only be taken if it aids formulating a diagnosis or enhances management of the tooth with an endodontic problem. So personally, I don't think it aids the diagnosis of which tooth is contributing to a ridiculous cyst. But if you are going to take a surgical approach, then it may help in planning the surgery, the access, or at least the lesion and the defect that you might be dealing with prior to undertaking the procedure. Sensibility testing can definitely help and give a true outcome of potentially which tooth might be involved. And I'm not sure how many people routinely undertake sensibility testing. Certainly, if you find a radiolucency and there is a particular tooth that is not responding to sensibility testing, it's a good positive indication that this is the contributing tooth. Equally, if we do sensibility testing on teeth and we find that all the teeth are responding positively, then again, we have to hold back, not damage the teeth, not to intervene, and then work with our colleagues to say, well, I'm not sure if this is a tooth-related ridiculous cyst, because potentially it is something else. And in terms of sensibility testing, there are various things out there. Commonly, people talk about using something like ethyl chloride, which is a cold thermal test. Actually, this only goes to -5 degrees. And it's very, very difficult by the time you apply this to the tooth, the temperature has already risen and you don't get a true reflection. Other things that are out there can take the temperature down to -50, and when you apply something that cold to a tooth, the patient, if there is vitality and a nerve supply in the tooth, patient will definitely feel it and you'll get a more reliable response. I personally like to also use an electric pulp tester, which I feel gives me even more information and a more definitive response. So it's not rocket science. It's no clever tool, no clever technology. It's something that we've been using for a long, long time. But many a times I'll get called by my colleagues in oral surgery or oral maxillofacial surgery to come and give an opinion on something. And the only thing I really take in my pocket is something to undertake some sensibility testing. And very quickly you can identify if there is a tooth that is contributing. Now, if you get a positive result, there may be a tooth that might be multi-rooted, and it might be one root that has still got some vitality. But at least you can stop and think before you just dive in and undertake multiple endodontic treatments or even extraction of teeth unnecessarily. If we were to take a surgical approach, here we would most certainly disrupt the blood supply and nerve supply to potentially vital teeth that are all involved within the cystic cavity or area, and therefore maybe stepping back and doing the endodontics first on the tooth that is maybe not responding to sensibility testing is a more conservative approach, and then we can monitor to see if there is healing, and if there isn't, then we can go in and undertake a surgical approach. And then we have to make the decision that if there are still other teeth involved within the surgical site, is their blood supply going to be compromised, and in which case do we undertake the endodontic treatment prior to surgery or post-surgery? And I guess there is no evidence-based answer for this, but if you're going in to do surgery and you want the wound to heal without infection and anything that might contribute to a post-operative complication, then it may make sense to say, okay, we'll have a discussion with the patient and consider elective devitalization through good quality endodontic treatment prior to elective devitalization through surgery, and then having to quickly get in there and do endodontics afterwards to prevent any complications. It could be argued either way. Some would argue that, well, actually, I wouldn't do that. I would do the surgery, and then post-op, I would do some sensibility testing. And if there are signs of loss of vitality, only then I would underdo the endodontics. And I guess it depends, it might vary from case to case. So I've just already mentioned about doing the orthograde treatment and the advantage of that. So will orthograde endodontic treatment work? Well, really, it only boils down to this one principle. If you have a true cyst where the tooth is not in connection with the cyst, it is not going to work. But if you have what we call a pocket cyst, where there is a direct connection between the tooth and the cyst in a typical radicular cyst, then the endodontic treatment will stand a good chance of working. So there we go. Lesion is separate from the apex, it's not going to work. And if it is in connection or continuous with the apex, then it is likely to work. So this case you've been seeing the radiograph for, we undertook endodontic treatment. The upper left lateral incisor was actually non-vital according to sensibility testing. Also, the lesion is centered around this. So we undertook endodontic treatment there, and we redid the endodontic treatment on the upper left one. And after a year, we saw the patient again, and we take a radiograph, and you might say that there is started to show signs of some infill, bony infill, but we can't really be sure. It's a radiograph taken at a different time, slightly different exposure, maybe slightly different angle. And so it looks like it's healing, but are we sure? So we don't just rely on clinical radiographic symptoms. Obviously, we rely on how the patient is presenting clinically, making sure they're asymptomatic and there are no signs of any discharging sinus or anything like that. And again, if I go back to my guidelines from the European Society of Endodontology, what they suggest is that we should be, the root canal treatment should be assessed after 1 year and subsequently as required. And basically, we're looking for absence of pain, swelling, sinus tract, and starting to form a normal periodontal ligament. So, okay, this is a 1-year review. I just said to you that I'm not 100% sure whether this is heading in the right direction. What do I do? At this stage, do I deem this as unsuccessful and then go and now assign the patient up for surgery, or should I wait longer? Well, the guidelines go on further, and it says if the radiograph reveals the lesion has remained the same size or has only diminished in size, the outcome is considered uncertain. So maybe this is where we are. This case, you might say at 1 year, it hasn't really increased in size, but it's remained about the same size and possibly slightly, some infill is noticeable. So maybe we are in a situation where the outcome is uncertain, but maybe heading in the right direction. And what they say here is that you should monitor this continuously further for a period of 4 years. And then interestingly, it says if the lesion persists after 4 years, then the root canal treatment is usually considered to be associated with post-treatment disease. I would certainly take that with a little bit of caution, because if it's just 4 years and 1 day and the patient is completely asymptomatic and there is definitely showing signs of healing, I wouldn't necessarily at 4 years and 1 day start talking to them about a further intervention. I would probably still like to continue monitoring. but it certainly shows that there is a period after which maybe we have to start thinking about alternative treatment. So I continued to monitor this patient. 2016, you can certainly see there is now improvement, and then 2017 as well. And I'm pretty confident that this is now healing just from undertaking endodontic treatment. However, there is on the just on the distal aspect of the upper left lateral incisor, a slight radiolucency where normal pre-DL hasn't really formed, and there is a little bit of a persisting radiolucency there. And you question what could this be? So it could be obviously persistent infection, which later on might translate to something recurrence or the lesion getting bigger. However, there is this concept that when a large lesion starts to grow, reduce in size, it may reduce in size substantially, but some area of radiolucency might be still left. And this area is often considered maybe some scar tissue healing around the tooth. So again, I wouldn't dive in. I would wait and monitor clinical symptoms, patients' presentation of any pain, discomfort, anything like this, in combination with what we are seeing on the radiographs. And if everything is staying stable, then I don't think any further invasive treatment is necessary. So I've just shown you a case of whether orthograde treatment works. Yes, obviously it's just one case and with limited time, rather than throw loads of x-rays and just show how amazing we can be at improving things. Hopefully that has shown you a journey and the thought process that I go through in terms of trying to decide how to manage these patients. So a conservative approach is always the treatment of choice. By just doing one endodontic procedure, we would manage this cyst and it's avoid the patient other invasive treatment. But what does the evidence say about success of endodontic treatment? Well, here is a study at the Eastman Dental Institute, which is commonly cited here in the UK amongst our endodontic colleagues. And it looked at a large number of teeth in a large number of patients over a reasonably long follow-up. And they basically provided outcomes for primary root canal treatment and secondary root canal treatment, so retreatment. So, and when I put strict criteria, they had strict within the paper, they have outcome based on a strict criteria or a slightly looser criteria. And strict criteria is complete radiographic healing, and the slightly looser criteria is where clinically asymptomatic, reduction in the radiolucency, but not complete healing in terms of radiographic radiolucency. So if we even just looked at the strict one, which is likely to have a slightly lower success criteria, we've still got reasonably high success rates. And if we apply a looser criteria, then the success rate goes up into the 90s. Now, when you've got high success rates like that, without a surgical approach, we certainly need to be thinking about this as a valid treatment modality. And just to say that a lot of the work that was presented within this study was treatment carried out by postgraduate students and not necessarily specialists in endodontics. The paper also then goes on to identify some prognostic factors which may influence the outcome of endodontic treatment. Now, this is important for endodontists who are undertaking the treatment, but also for the whole of the audience in this symposium, because even if you're not going to undertake the endodontic treatment, you can certainly look at some of these prognostic factors, either on radiographs or discussing with the patient to see if some of these parameters were met to ensure that the endodontic approach has been the best it could be. If these prognostic factors have not been met, then maybe there is still an opportunity to speak with the endodontist and say, look, this person has had endodontic treatment, but certain things weren't done, and maybe that's why the outcome is not as positive as it could be. Maybe it may be worth revisiting that before going down a surgical approach. So certain things are presence of a periapical radiolucency. Well, as soon as we're dealing with a cyst, we're likely to have that present. Discharging sinus, root perforation, size of periapical radiolucency. So all of these things on the left, if they were present, they would decrease the prognosis and the success rates. So those high numbers that we were seeing start to drop because of these things that are present. Then in terms of treatment, if the endodontic treatment goes right down to the apical, to the apex of the root and make sure there was apical patency, the distance the root filling is from the terminus of the tooth, whether the tooth has, how the tooth has been disinfected, the use of sodium hypochlorite is absolutely essential, and making sure it's not combined with chlorhexidine, which can create a precipitate which actually drops the success rate of endodontic treatment. Again, things like no sort of flare-ups between appointments if the treatment is done over multiple visits, not having an overfill. So if the root filling is beyond the apex, this is likely to drop the success rate. A good coronal restoration. So has the tooth got a good seal? If you look at a tooth and the tooth is broken and saliva has been leaking in, clearly that is not going to help. And even if you take a surgical approach, if the tooth is still leaking, the chances are that the outcome of the surgery may be affected as well. And then in retreatments, there is definitely advantage if 17% EDTA has been used as a penultimate rinse prior to the final sodium hypochlorite rinse. So, you know, some of these things could be discussed either with the referring dentist or with the patient to see whether some of these things were done. Also, you can look at the quality of the fill on the radiograph. If it doesn't look great, you can always ask your endodontist to take another look and see if they can improve. I guess from a cyst point of view, these two factors are the most important. And what do they say? So a periapical radiolucency, as soon as you have a periapical radiolucency present around a tooth, the success rate of endodontic treatment can be dropped by about 49%. So that's a significant reduction in success rate as soon as we start seeing periapical radiolucency. But not only the presence of a periapical radiolucency, even the size of the periapical radiolucency. So as the size of the periapical radiolucency increases, the success rate starts to drop, which when we're talking about cyst, these two have a clear impact. So will orthograde endodontic treatment work? Of course it will, provided it's a pocket cyst, but a cystic lesion has a significantly reduced success rate of orthograde endodontic treatment purely from those prognostic factors that I've just mentioned. So should we just consider a surgical approach? Why should we not? Why should we undergo primary root canal treatment? So for me, primary root canal treatment, so non-surgical orthograde approach is still the treatment of choice. When it comes to retreatment, if the quality of the root canal filling is poor, then non-surgical retreatment is definitely still the treatment of choice. Because unless you get these things right, even your surgical outcome could be compromised because the offending tooth or has still potential for leakage and continuous leakage into the apical area, tissues and things like that. So you need to get the causative factor corrected first before you can before even your surgery should come. But if you have a good root canal filling, so if I have done the primary root canal filling or if I have done the retreatment and I know that I've not left any stone unturned, everything has been done as per the literature, then and the tooth has got a good coronal seal and the lesion is still not responding as I would want it to, then I would go for a surgical approach and maybe not even do a retreatment. So non-surgical versus surgical, what does the literature say? Well, here is a Cochrane review. They looked at 20 randomized controlled trials. They obviously found the quality of the studies to be low, but what they did conclude that there seemed to be no difference between a surgical and an endodontic orthograde approach at 1, 4, and 10 years. But what they did say was that the surgical option resulted in more post-operative pain for the patient. And that is an important factor to consider. There is a patient at the other end of this And so whatever option we undertake, we have to think about what the patient is going to suffer or what the journey the patient is going to go through. And obviously, as with all Cochrane reviews, they said the available evidence is not enough and we need further research. However, that doesn't mean that the available research evidence doesn't give us any information. And if we look at some of these studies, here's a systematic review by Tora Binajad in 2009, and they showed that the success at 2 to 4 years, and then the success at 4 to 6 years. And the success in the early stages is maybe surgery is slightly better than redoing the endodontic treatment, but over a longer period, the orthograde endodontic treatment significantly outweighs the success of surgery. And that might be because if the endodontics hasn't been correctly revised and you undertake surgery, obviously in the short term you've eliminated the lesion and it will be fine. But if the tooth is still leaking bacteria, then there is a good chance that maybe things might come back and present again. So evidence is not great, but surgery showed a significant decrease each year of follow-up, whereas retreatment showed an improvement for each year, which is very interesting. And again, it may come down to case selection and surgical technique. So talking about surgical technique, obviously in endodontics, we undertake microendodontic surgery. And this is slightly different to the more traditional techniques for what we would call apical surgery or apicectomy procedures. So here is a study which looked at 7 RCTs and 6 prospective studies, 8 retrospective studies, and they compared a traditional technique versus more sort of modern technique. So traditional technique using surgical burrs, beveled incisions, exposing more dentinal tubules, and the use of amalgam as a retrograde filling material. Whereas a more modern technique uses magnification, microscope, ultrasonic root end preparation, use of microsurgical instruments to be able to look into the tooth, a bit similar to the endoscope, but not quite advanced technologies. It's just a small mirror. And then sort of perpendicular root resection to avoid exposing too many tubules, which can result in leakage and things like that. And then the use of alternative materials for root end sealing than amalgam. And what they found was a huge significant difference. The traditional technique had a success rate of around 59% at 6-month follow-up, whereas the more modern technique had a 94% success rate at 6 months. And that was a significant difference. And this certainly in our unit, a lot of the endodontic surgery for surgery for radicular cysts or periapical granulomas are now done in the restorative department and with the endodontic team. So just to sort of end up, I just want to talk you through, show you a modern apical surgery technique and how we would approach it. So this is a patient who presented 2 upper central incisors. They have huge cast posts and crowns. They have an endodontic treatment in the apical third. And the first thing I do is, okay, so look at the lesion. It looks like a large periapical radiolucency on both of these teeth. Probably a cyst, could be a large granuloma. We don't really know. But then the next thing I'm thinking is, how am I going to approach this? Now, I could dismantle the crowns, try and take those posts out, and try and redo the endodontics. But the endodontics looks reasonably good quality. It's within 3 or 4 millimeters of the apex. It has got a good solid fill. The post has a good fit, and the crowns have a good seal. So there is no micro leakage from the crowns or the post. The root filling is good. Now, if I try to dismantle that, there is a good chance that I'm going to crack the teeth or fracture the teeth trying to get those posts out, and the patient may end up losing the teeth. So in this case, I decided to accept the endodontic treatment and undergo for a surgical approach. Now, the risk we have here is the patient has a high smile line and has got 2 crowns in the anterior region. And already you can see around the upper right one, there is some margin showing. So you have to be very, very careful when you take your surgery that at the end, you don't leave the patient with a huge amount of recession or the crown margins exposed. So to avoid this, we would take a papilla preserving flap where we make some relieving incisions and then crevicular incision around the tooth. And then we leave this diamond-shaped papillas in place and erase the flap, as you can see in the picture. I then reflect the flap and then expose the lesions and we remove the lesion and again try and remove it all in one if we can. And you can see here the upper right central incisor has a huge lesion on it, whereas the upper left is slightly smaller. We then go in and resect the root ends and try and do this perpendicular 90 degrees to the long axis of the tooth to prevent exposing too many dentinal tubules, which seems to have an impact on the outcome. This can be either done with a surgical burr, with a surgical fissure burr, or a reverse jetting fast handpiece. Once this is done, then we use our ultrasonic technology to prepare the apical root end to remove any bacteria that might be sitting around the apical region there, remove any GP, and create space for our apical plug. We then check with micro mirrors and things like this, and then we plug the root end with our root end filling material. And I commonly would use MTA as the material of choice. Essentially, the outcomes of the different materials is not that dissimilar, so you could choose whatever works in your hands. In this case, we then decided to undertake some guided tissue regeneration, particularly in the larger bony crypt. So I filled this with a bone graft, which is a deproteinized bovine bone matrix, and then covered it with a collagen matrix. And the reason to do this is to encourage and ensure that we get the maximum bony healing in this area. One of the things that I do a lot of, as well as endodontics, is rehabilitation of dental trauma patients. And so endodontics and rehabilitation with dental implants are kind of my everyday work. And the last thing you want is you have a big bone defect and then you're trying to place implants. So whenever I am undertaking endodontics and I've already raised a flap here, I see this a potential opportunity to correct the bone defect, because at some point in the future, these teeth may be lost. And maybe if I've done something to leave a more favorable situation, that may make subsequent rehabilitation less invasive. I have sometimes placed bone and a membrane. Sometimes I have just placed a membrane, because essentially there is an argument to say, actually, if you don't put anything, you will still get bony infill. But my worry is that maybe in some lesions, maybe not in this one, but some other lesions, there might be soft tissue collapse. So maybe putting a barrier and letting a blood clot fill without any bone substitute may work. Now, I don't do this all the time, and I don't have hundreds of cases to be able to give you a true guidance on exactly what you should do. But the principle of guided tissue regeneration from our periodontal literature is basically what I have applied in a multidisciplinary way to managing this patient's as part of their endodontic journey. So I'm kind of combining my knowledge of periodontology and endodontics and future prosthodontic rehabilitation as well, all in one, right from the outset of treating this patient, so that later on I have got some plans in place when this treatment may fail. So this is the post-op outcome at 1 week. You know, there is a little bit of inflammation still there, but the wound is coming together nicely. And at 3 months, we're almost back to where we started. There is a little bit of scarring in the relieving incisions, but the papillas have healed nicely. Still a little bit of scarring, maybe between the two central incisors, but certainly we haven't got any more recession than we did when we started. And this can be seen in the pre-op view and the post-op view. And this is very, very important, particularly in current day and age, in the anterior aesthetic zone, where patients are smiling and talking. And if they have a high smile line, it is very difficult to manage. Obviously, you could change the crowns and things like this if you did get some recession, but obviously this adds to more cost and more treatment for the patient. Radiographically, this was at 1 week, and you might say, oh, wow, great bony infill, but obviously I've put bone in there, so that let's not be misled that that is healing. But on the left central incisor, that is natural cavity that's present. At 3 months, you can see that the bovine bone graft is starting to consolidate, but there is still a demarcation between the native bone and the bone within the cavity. And finally, and you can see that the upper left central incisor is slowly healing away. So I left this and we monitored, and the patient came back at 1 year, and I was happy to see the upper left one has pretty much fully healed, and there is almost like a uniform PDL space around the tooth. And then the upper right one, it seems like there is now a nice blend and consolidation between native bone and grafted bone. So this now in the future, if the patient now loses these anterior teeth, we have made some attempt to leave a more favorable situation. So should we be taking this kind of guided tissue regeneration for all surgical endodontic treatment? So when I go to literature, I found a systematic review and meta-analysis. And actually, there's not a lot of literature out there. 5 studies, the results were not statistically significant. And most of these studies with various materials all tend to show trends. So the trend shows a better outcome with guided tissue regeneration cases. But just because something shows a trend, there's also an added cost to the patient, and it's got to be balanced between, is it worth that extra cost to just follow a trend? And that last case, you can see, may have just healed like that without any regeneration at all, you know, or maybe just a membrane. And so we have to, obviously these are good options that we have up our sleeve, but we shouldn't apply them as a generic to all, and we should be on a case-by-case basis, depending on what the future plan might be. So if the patient is unlikely to go on to maybe have extensive implant rehabilitation and things like that, then why would you even want to think about putting something like, or putting the patient through these extra treatments? But we need more information, and more research is obviously required in this area. So just to summarize, if we try and answer some of these questions again, can endodontics alone treat cystic lesions? Well, it can only treat radicular pocket cysts. Success of endodontic treatment is high, but the presence of the periapical radiolucency, which is often associated with a cystic lesion, decreases the success significantly. The larger the lesion, the poorer the outcome of orthograde endodontics alone. But good quality endodontic treatment can still treat large cysts, but can also aid the outcome of surgical treatment, because a poor endodontic treatment is likely to continue leaking bacteria into the apical site. Non-surgical approach preserves vitality of adjacent teeth. Good quality endodontic treatment is essential prerequisite to surgery, as I just mentioned. When do we do root canal treatment or retreatment before or after enucleation of cysts? I think I've already addressed this. Endodontic treatment should always be completed first, in my opinion. Reduces the risk of post-op complications following surgery, eliminates bacteria from the root canal system. Cost implications, well, surgery is more costly than a non-surgical treatment. Surgery often is carried out by specialists or hospital setting, whereas orthograde endodontic treatment could be carried out by good general dental practitioners as well. Long-term results, either the same or worse for surgery. Surgical technique used can significantly affect the outcome, and modern surgical techniques require more costly equipment, but can result in better outcomes. Usually the equipment costs are upfront costs. So once you've invested in these costs and you've got all the tools, then there is no ongoing cost per se. So can surgery alone treat inflammatory radicular cysts? No, I don't think so, because surgery alone in the presence of an infected root is likely to compromise the surgical outcomes. So with that, I thank you for your attention, and I hope that was thought-provoking and useful to the audience.
Thank you. Thank you, Dr. Mittal Patel, for your enlightening presentation. It was so informative, sir, and you explained all the aspects very well. I found the part about the modern microapical surgery and guided tissue regeneration very interesting. Thank you. Thank you once again.
Thank you.
Jim, would you like to proceed with the panel discussion? Yes, I think.
Yes, please.
So I have picked up some questions from the question and answer section. Shall we proceed?
Yeah, you can.
Yeah.
Okay. To start with, I think the oral medicine department deserves some questions, more questions to them. Either Dr. Nalini or Dr. Bhagyalakshmi can take up these questions. The first one is about the difference between cyst and tumor clinically. Is there a strong point by which you can say it is a tumor or cyst clinically? Dr. Nalini is here. Yeah.
They both have to switch on the...
Yes, you are muted, Nalini and Bhagya.
Yeah.
Yeah, I'm here.
Okay.
I feel most often a tumor causes bicortical expansion.
Okay.
Most of this is they cause unilateral expansion except for OKC.
Okay.
That's my opinion. Radiologically, tumor causes more resorption, but clinically, I think bicortical expansion is a clue that it could be a tumor.
Tumor. Okay.
Yeah, I agree with Dr. Nalini. It's when you see bilateral expansion on imaging, I think the emphasis will be more on ameloblastoma. In addition, if you see a lot of resorption of teeth, because it's an aggressive tumor, so it tends to expand more and destroy the structures on the way.
Okay, the second question is in the same context. Why doesn't the cyst expand the lingual cortex?
It does expand lingually depending on the position of the tooth and depending on where the origin is. Say, for instance, if it is a lateral incisor radicular cyst, tend to cause more palatal expansion. And if it's a dentigerous cyst associated with more lingually tilted teeth, then you tend to see more lingual expansion. I think by far it's common to have buccal expansion with most of the cysts by the nature where it originates from.
Yeah, we'll pass on to the next question, which says, what is an apical basis? BAY. Sir, yes, sir. Judge Paul, sir.
Yeah, I just wanted to make a small point here.
Sure,
a case
sir.
I came across recently where there was no root resorption. The teeth were all floating in the premolar incisor region. And it was obviously a very aggressive lesion because it didn't have any cortication on the bone. And it looked like a cyst, of course. In fact, somebody sent it to me saying it was a cyst. And it ended up being a very high-grade mucoepidermoid carcinoma. So in those kind of situations, although it is a tumor, you may not find root resorption because the bone goes away so fast. You have paresthesia, but you don't have root resorption.
Root resorption, yes.
It's a point,
Yes,
I think.
Can I just add on? That's a very good point, sir. I think the topic was restricted to cysts, so we didn't really discuss about the tumors. But one of the major differential feature to see if it's an aggressive lesion, the aggressive tumors tend to grow along the least path of resistance, so they grow around the PDL space. So it doesn't really try to resorb the teeth, whereas you get almost like a spiky sort of pointed resorption, or just the edge of the tooth becomes very enhanced because the lesion is growing within the PDL space. So that's one of the sort of a warning sign when you think trying to differentiate with the cyst and carcinoma.
Most often, the malignant lesions do not produce the characteristic radiographic appearances. They will give some bizarre appearances.
Yeah. I think the key alarm signs is if you see localized severe alveolar bone loss, which is out of proportion with the rest of the quadrant, then you need to, the alarm bell should go on. Why should suddenly there should be rapid periodontal bone loss? Sort of irregular permeative pattern of destruction of bone where you can't really draw the margins with it. And these lesions tend to be non-corticated, and trying to differentiate from an inflammatory process. With almost malignancies, you don't really see the sclerotic process happening on the periphery, because the benign process, that's the reason why you get the corticated margin. There'll be more bone deposition at the edges, whereas aggressive tumors, the body doesn't react to it. So you don't really see a corticated margin. And it actually goes through the ID canal cortices rather than displacing it. So when you see those alarm signs, I think you will be more cautious and go for an urgent biopsy.
Thanks for that, Dr. Bhagia. So the next one is on apical base cyst. What is an apical base cyst? Bay is B-A-Y. I'm not very familiar with this terminology. Any idea? Anyone can explain?
I think Mittal has covered that, isn't it? Yeah. Because it's kind of a true cyst versus pocket cyst. I think for us, it's not common to be called as apical basis, but it's literally what Dr. Patel has already said.
So
true
is the pocket
is separate.
Pocket cyst and the basis, they are the same. Okay.
Yeah. So yeah, basis, you have it communicated with the
root canal.
Yeah. You can't really differentiate that on imaging. I think the key diagnosis of radicular cyst is if you find the corticated margin of the cyst in continuous with the lamina dura and the central radiolucency continuous with the PDL, you can say that it's a radicular cyst, but you can't really classify that as a true, it's just an histological diagnosis.
So another question directed to Bhagyalakshmi. How do you make out a vascular lesion in the conventional X-rays? 2D.
Vascular malformations, it's very, very misleading. It can mimic anything. I can tell you cases where it looked like a large sort of multilocular lesion, or it could be like a fibrosis lesion. One thing I could say is extremely rare. Common things are common. And it can mimic anything. And I think the case I showed, it was within the ID canal, so you could put more emphasis, but I'd seen cases where you wouldn't have guessed it. As soon as the surgeon put the needle in, all they could get was the blood. So it's a big mimicker. And I think when things are not very clear, I don't know, it's best to start off with aspiration rather than chopping the bone. But one of the sort of feature you would like to look for, especially if you're looking at intraosseous hemangioma, you get almost this tiny little sort of dark holes within the bone. It's not the usual multilocular pattern. You get like as if little holes within the medullary bone. I think when I see that sign, I'll be more on the cautious side. It's probably a vascular lesion. It's very hard to differentiate.
Vascular lesions most often give good clinical evidence than radiographic evidence.
Okay.
Right.
Yes, sir. Sir, yes, sir.
I just wanted to make a point there. So when you're talking about a vascular lesion, you might be talking about a hemorrhagic cyst or an aneurysmal bone cyst, which even if you open surgically, it's okay, because if you curate it, it stops. But if you're looking at an AV malformation inside the mandible, then those who believe in God help you, because it can be extremely bad.
Yes. Yes, sir. Okay. Yeah. The next questions are directed to the Department of Oral Pathology. Dr. Pratibha or Dr. Selvam can take up these questions, I think. Okay, if there is a cystic lesion in the erupting upper premolars region, but there is also associated carious primary molars. So how do you establish whether it is a dentigerous cyst from the unerupted tooth, or it is a dental cyst from the carious primary molars? Is there a way, clinically and radiologically?
I think radiological features would be more favorable to narrow the differential diagnosis. Because if you see a follicle separate from the whatever the cystic lesion you're seeing, then you can almost be certain it's not a dentigerous cyst. But if you see it continuous with the follicle and very typically attached to the cemento-enamel junction or extending to CEJ, then you're dealing with the dentigerous cyst.
Yes,
maybe a couple of other.
Yeah, I totally agree. Yeah, please.
After you, Dr. Pratibha, after you, please.
Yeah, as ma'am had rightly said, when we receive the specimen, mostly if it's a dentigerous cyst, it's associated with the neck of the teeth, however, wherever it may be. And clinically, we ask the clinicians for the vitality of the teeth, just in case they are dealing with the primary molars. And pretty much, I think these two entities can be differentiated very well with clinical and radiographically. With histopathology would be a sort of giving the final touch to it. So I think it's more or less more clinical, radiographic, and finally with the grossing itself to some extent, we can say that it could be a dentigerous cyst. And of course, one of the things, since they had mentioned it with premolar and those areas, it's a maxilla, a young child, at that point of time, again, AOT would be another important differential diagnosis.
It might depend on the duration of how long it's been there and whether or not there was any degree of inflammation. There may be some hints that favor one over the other. If, for example, there are areas of reduced enamel epithelium-like lining, a bilaminar zone of cuboidal cells, that might favor, in the appropriate context, a dentigerous cyst over the radicular cyst. Likewise, it depends also on the non-epithelial structure. So there might be some indication that the wall has a phenotype of a dental follicle that might help push one over the other. But like I say, these things can be quite difficult. It depends on several factors. But there might be one or two clues that we could look for.
Can I just add one more point to Dr. Pratibha on the AOT, adenomatoid odontogenic tumor? And one of the radiographic clue is the lesion, though it's small, it doesn't stop at the CEJ. If you see it extending into the root surface for the small size lesion, you really need to include adenomatoid odontogenic tumor in your differential. At later stages, it does calcify and gets a classic picture. But in early stages, I think CEJ is the key point to look radiologically.
Thank you. There is a common question. Can you hear me?
Yes, sir.
Okay. There is a common question. Anybody can take up this one. So is OKC a cyst or a tumor? Is the debate still on whether it is a cyst or a tumor, or do we have a consensus today? Can we start with Dr. Nalini?
I favor both. Sometimes it behaves like a tumor, sometimes it behaves like a cyst.
So there is no consensus?
Because now the WHO has changed from tumor to cyst. Probably based on the number of cases they have reviewed so far, they would have changed it as a cyst. I do not know. I still put a question mark whether it's a tumor, to be given as a tumor or a cyst.
Okay, Dr. Bhagya?
I think that's a very important point, as Dr. Nalini said. Some operations, they behave like cyst and some are like tumor. I think from radiological point of view, what I've seen from my experience is unilocular tend to be more like cyst. Whereas whenever I come across a multilocular lesion, especially if I see like tiny little radiolucencies at the edge of the lesion and some of them wrapping around lingual to the teeth, adjacent teeth, I think those are the ones that start behaving more like tumors, because those are the ones I tend to pick up more recurrence rate, because it's very hard to pick that tiny lesion at the edge.
Okay. Nice point to be taken. Sir, GP sir,
Can
your
I-
opinion
can-
on that, sir?
Well,
Yeah.
I think I mentioned it in my talk. I would still consider it a tumor, really, because various reasons. I mean, I think there are some similarities to BCC, and especially in the syndromic variety. You have genetic predisposition to it. The behavior is not typically what we would expect out of a cyst. But I think somebody asked a question: what was the reason they gave to downgrade it back into a cyst from a tumor? And I remember reading it is a clonicity. I think that they have a cloning criteria to classify something as a tumor, and I think the OKC did not meet that cloning criteria. So the clonicity was you need to have a primitive cell from which the tumor develops. So I think that was the issue based on which I'm sure Supreet would have something to say on that. I don't know.
I fully agree. The reason and the way that I look at this, the entire reason that the OKC has originated is because there has been a breakdown in the tumor suppressor pathology. That is the entire reason that you have OKCs alongside everything else. So this is not a normal physiological process where a cyst is formed. I view this very much as a tumor. Now, at all points, this acts like a cyst. It has a lining that produces keratin. But as my other colleagues have said, it often behaves as a tumor. But my view as a surgeon is actually, if you go right back to the pathology, every single one of these patients has an abnormality in the patch gene, and the role of that patch gene is actually to prevent tumors, and that is why these patients have this. So I sit very much on the side of this is a tumor, and we should treat it as such. So I'm on team Professor Paul's side on this.
Dr. Candy?
I think I'll wait for Dr. Selvam to say why the orthokeratinized variety was separated from the OKC. I think that's a key thing. My second worry is the moment you give the name tumor, the surgeons get excited and they go into resection. The number of cases I've seen as a straightforward resection, as soon as they see KCOT, I think that is a bit unfair on the patient side. I was so glad he was downgraded from the tumor to cyst, and everybody started going back to, sort of a minimalistic way of treating the patient. So from the name point of view, I know the behavior is completely, utterly different to other cysts. I completely agree with that. The name tumor excites the surgeons, which I'm a little bit worried about. I think Selvam needs to say why the particular reasons why the cell behavior is slightly more different to other cysts. I think Selvam needs to say about it, and especially why OKC is separated away from orthokeratinized cyst, and that made it easy for the pathologists and the surgeons as well, especially for patients. Let Selvam talk first, and then I'll come back to that.
Well, thank you very much, Dr. Kandasamy.
Dr.
I'm not sure if I've got any words of wisdom to add. I know the next edition of the WHO Blue Book classification is already being considered. And I have one of my colleagues, Professor Eddie Odell, as a prominent figure in the area of oral pathology, is on that committee. And I know the WHO at the moment has no intention in the next edition to reclassify this as a tumor. The problem with tumor, it's a rather broad spectrum that encompasses everything. Is it truly a neoplasm, or is it a developmental anomaly? My personal view is that I don't feel very strongly either way, as long as we all know what we're talking about. I would also caution slightly about reproducible and consistent mutations, because we know that even inflammatory or other conditions, or pre-malignant conditions even, can have very consistent single gene alterations. I'm thinking about multinodular goiter in thyroid, for example. RET PTC and RTK and all that are very equally, and that's not malignant. I appreciate we're not talking about a malignant entity here, but like I said, I don't have any strong feeling as long as pathologists, surgeon, and radiologists know exactly what we're talking about. There may come a point where we further classify things. Okay, so for example, I didn't touch on this, but I'm sure Dr. Pratibha would elaborate if necessary, or correct me hopefully if necessary, that in the syndromic cases, yeah, there are one or two hints that might suggest a more aggressive phenotype. You know, we often see budding of a Ricci process formation. We see lots more islands in the wall, and lots more, you know, satellites, and a slightly worrying, you know, expansion of the basal compartment. All these kind of things. I mean, maybe that we then further at some point down the line, from a whole exome or molecular profiling, be able to separate out those that are aggressive from those that are not aggressive. But I'm not sure we're there yet. But there are some phenotypic changes between the two. So I'm sorry I can't be definitive on this, Dr. Kandasamy, but my view is it doesn't matter as long as we all know what we're talking about.
Also, Selvam, the 2017 classification came. The orthokeratinoid was completely separated away. Previously was under the umbrella of KCOT, wasn't it?
Yes, right. Indeed. Oh, sorry, might lost someone. Yeah, you're absolutely right. And there again, because we often put lots of features together, okay, to make a diagnosis, not just a single feature, okay? So with the orthokeratinizing odontogenic cyst, we, for example, don't often see very prominent basal palisading. We don't often see a corrugated surface architecture. We don't often see the infolding, it's sort of the infolding of the epithelial lining, so that, when your plane of cleavage comes out and you cut off a little bit. I think the best thing that the WHO did in separating out this entity is to make the point that recurrence rates are almost nil. So it can be treated in a much more conservative fashion. Also, we haven't got the molecular profile that we see in the classical odontogenic keratocyst. I hope this helps.
Sir, can I add my views on this?
Yes, Dr. Pratibha, please.
Yeah, I totally agree with Selvam sir in the fact that generally, when as pathologists, when you get an OKC, if it's a classical OKC with the classical feature as the slide which he had shown, I would just go ahead and say, treat it as a cyst. Whereas if we are going to see budding, satellite cyst, daughter cyst, granddaughter cyst, and then if there is going to be somewhere along the line, we try to do some immunohistochemistry, if that's a case is there, to help the surgeons. And if it's going to be inflammatory, all the more inflammatory secondary changes is there, all the more confusion is there, because that can lead to certain cytokeratin change profile. So what we try to do is we give a sort of an immunohistochemistry profile to the surgeon, like we do BCL2. Like, since syndromic cases are considered to be more aggressive, BCL2 and the CK, and we know that BCL2 is the end pathway of the CHH pathway. So that the expression pattern in the cyst epithelial lining, that to some extent helps us. And also, like literature says, I have not done, like a few studies have used some rankle and syndekin as IHC, that's commonly used IHC markers, through which if they find it to be positive around with the epithelium and the adjacent areas, then they report to the surgeon telling that this could be more aggressive type and you can treat it accordingly. So in that way, we have done quite a number of studies, given PG theses with this topic. And so whenever it was convenient for us to behave, when we are given markers with related to tumor, we were almost sure that we wanted to write it as a tumor. When it wanted to be a cyst, it was a cyst. So I think most of the literature goes by what the studies are, what the current trend is, rather than actually helping the surgeons on how to go about it. So I think when you get a classical cyst with no tumor budding or just a cyst-like entity, treat it like a cyst. But if you're going to get additional features, as we had mentioned, with some of these, BCL2 is a basic marker which is available almost with all the labs, that could help the surgeon. So that is one important thing. And with regard to Candy sir asking with orthokeratinized OC, the odontogenic cyst, I think right from the beginning here, I think Suresh sir and everybody would agree, we had never treated as KCOT, sir. It was always considered only as a cyst, and all our surgeons usually treat it only as a cyst, and they never considered it to be a tumor, because right from the beginning here, all the three departments have considered it to be only like a cyst, and they have treated as a cyst, sir. I think sir could give more idea on that.
Yes,
another question to Stelvam again. I know I've asked this question before in our panel discussion, but I thought I'll ask you again for the audience, for the sake. You know, the decompressed ones, like, do they change the behavior in cellular level?
Absolutely. Absolutely. This highlights the sort of the common origin, of the oral mucosa and the odontogenic epithelium, and this not just for cyst, this goes for ameloblastomas as well. When you have an ameloblastoma that's perforated the cortex and has fused with the gingival epithelium or the oral epithelium, it takes on the phenotype of the oral epithelium. Okay, there are one or two hints sometimes, but it does so. So you be careful. I say when you're biopsying those perforated lesions, there's some sort of dogma that says you always have to include normal adjacent tissue. I'm not entirely convinced that's entirely true, but be careful, because if you just take the surface off, it just looks like hyperplastic, oral epithelium. Interestingly, this is our observation. I'm sure Dr. Pratibha would concur. In marsupialized cases, once again, it takes on the phenotype of the oral epithelium. I haven't done any protein or molecular studies to see whether these have a similar proliferation index or a similar aggressive pattern of behavior. But my suspicion is genotype always follows phenotype, or precedes phenotype, I should say. And my instinct, I haven't got any hard evidence for this, but my instinct is the replicative potential of that epithelium is no longer what it is in the original cyst lining. I'm not sure if anybody else has got any further comment on that.
Sir, you can sum up the discussion. Yes, sir. Sir, you can sum up the discussion.
Suresh, most of what the pathologist said went over my head. Yes. I know that it has some kind of an activity around the hedgehog signaling system and things like that. That's about all I know. But I'd like to, I'd probably disagree with Candy in the aspect that because it is a cyst, we would treat it less aggressively, and because it's a tumor, we would treat it more aggressively. And I'd go with what Pratibha said, that in her unit, irrespective of whether it was a cyst or a tumor, they treated it the same way. That's the way I have always treated it. But I've seen one, in summation, I've seen one advantage. We have this, the Tamil Nadu CAPIT, the insurance scheme, the Chief Minister's insurance scheme. They would reimburse the patient if it is a tumor, but they will not reimburse if it's a cyst. So I always tell my pathologist, please write KCOT, which I sent for the insurance purposes. And so I still tell them that, even though it's become OKC again, because the poor fellow gets some benefit out of the government scheme. And mostly, as I said, most
that's
of my
a very practical point.
Poor patients, yeah.
No, I'm only, sir, George Paul, sir, mainly I was saying it because at the beginning, Dr. Veerabhagu was talking about dentures being resected and reconstructed and got infected now. And that's, we're talking about ethically, morally surgeon, they will follow exactly what we are talking about, and without any disagreement. What you're saying is absolutely spot on. I think it is also entirely depends on the pathologist. We give the right kind of a direction. Fortunately, unfortunately, I'm away from the teaching institution, so I get general pathologists giving the pathology opinion. So I kind of a struggle, and it is same for every non-teaching hospital in UK. They don't have oral pathology or well-trained head and neck pathologists like Dr. Selvam or Dr. Pratibha. So we rely on general pathologists. So. And that is where my anxiety comes in. They say it's a keratocystic odontogenic tumor. By the way, they haven't changed the diagnosis because they haven't heard it yet. So I still get a KCOT as a pathology opinion. I'm not saying to make it bad on the perspective, but the general pathologies are, they've got the vast from head to toe to learn about, so I can't really complain about it. But that is where the patients are affected, when we are not led by other team members and we go excited and go resected and stuff. And from that perspective, I'm talking about, if you're in a major teaching hospital and you have the support of Dr. Selvam or Dr. Prathipa, I don't think anybody will go wrong, and patients will benefit massively.
Just on the insurance purposes, I know that's one of the reasons why my American colleagues like to call things fibroma, because it implies a benign neoplasm as opposed to a fibroepithelial polyp. But that's by the by. Look, I think this forum is absolutely brilliant, because over and over it's highlighting the fact that we need to communicate, and communicate well and easily. I, as a pathologist, I work in a histopathology department that's away from the public front. It's hidden in down some dark corridor in some in the basement in a hospital that nobody knows exists. And we're always very keen to speak to our clinical colleagues. So sometimes you can't convey everything you want to in terms of its nuances and its subtleties on a written report. In which case I have no qualms in picking up the phone and speaking to my colleagues and say, look, I've called it such and such, but I've got a gut feeling about this. I think maybe in this condition, in this situation, you might have to do it such and such. And likewise, we welcome the odd phone call from our surgical colleagues to say, well, you've said such and such, but what do you mean really? Or I don't, I'm afraid I don't agree with you on this case because it's not behaving in a manner that that you have diagnosed. So yeah, over and over again, it's all about communication, really. So I hope this sort of brings all that out.
I think further to Dr. Thavaraja and what Dr. Ganesan raised, as long as the multidisciplinary team are in agreement, and really it goes further than that. Everyone does have to respect everyone that comes to the MDT. So if the pathologist doesn't feel empowered and respected, and that actually they're not just there as part of the furniture, they're imparting really quite important knowledge that we as the surgeons can learn from, then I think that's very, very important. And as Dr. Ganesan said, I know we like to cut and I know we get very excited, but that doesn't mean you can take off half the mandible when it's just a small cyst. And so I've seen this time and time again as a trainee. MDTs are not just there to fill the timetable. The pathologists and the clinicians and everyone else, they all serve such a valuable purpose. So again, going there not just because the report's up there and you're playing on your phone and watching Facebook, all these things are so important. We can always gather so much. Being open to that and empowering others is always so important. So I think that's been really well raised by everyone on the panel.
Okay. Any other comments on this, or we proceed with the next one?
Wow.
Sir, GP sir, the next question is a very interesting one, and I think you can be the best person to answer it. The question says, if the pathologist has made a wrong diagnosis, and if the surgeon has done a wrong treatment based on that particular diagnosis, who is liable for a legal action? Only you can answer, sir.
Yeah, in fact, well, I planted that question actually, because someone asked me and I said, okay, you just go ahead and ask in the chat box. They messaged me separately. So, see, this is a very important aspect which pathologists never address. The issue is, in fact, I remember Ranganathan talking to me about this, and the pathologist in Chennai, yeah, he spoke to me about it and said, I think he wanted me to speak at one of the oral pathology conferences on this issue. So does a pathologist actually have a liability in giving? I mean, if you give a diagnosis as ameloblastoma and somebody resects the jaw and then you get the whole specimen and say, oh, I'm sorry, it was actually a and if the patient knows enough that you have over-treated the situation, who will be liable? I mean, it's a question. See, it's an extremely complex set of reactions that come up, and I think every oral pathologist should know this. I have not heard of a single pathologist ever being sued. on account of having given. But the surgeon does, and rightly so, because in India we follow the tort law. That's a civil law. The civil tort is a civil wrong. So that is based on a contract. The contract is usually between the patient and the surgeon. It's not like the NHS, which is much more. There's a lot of vicarious liability which builds up into that. But in India, when you're in private practice, like I am, like Candy, I'm in the boondocks. I'm in a small town practicing. So what we have is we have this contract between the patient and the surgeon. So that contract is what the patient is going to hit when he is thinking of suing somebody. He's not going to be bothered about who was a radiologist who gave you a diagnosis, who was a pathologist who gave you the diagnosis. No, it is the surgeon who's going to be in the forefront. Now, the main problem is the surgeon should have a contract with the pathologist. And if there is a contract with the pathologist, he can transfer a part of his liability onto the pathologist. And we don't have that kind of a contract. So we just send it to different pathologists and things like that. And they make a mistake and you act on that mistake and you are held completely liable. So I think every surgeon should choose a good radiologist and a good pathologist. And when it comes to pathologists, I always choose an oral pathologist for all my oral lesions, because I think general pathologists go haywire with their diagnosis. I mean, I've seen extremely bizarre diagnosis coming out from them. So yeah, unfortunately for the pathologists, they escape liability most of the time, but there is a vicarious liability. So the surgeon can technically sue the pathologist, but the patient probably can't sue the pathologist. You understand? Or the radiologist.
Yes, sir. Yes, sir. Yes, sir. Well said, sir. Yes, sir.
This is based on English law, by the way. All those who are from UK, it's based on English law. English common law is what has been adopted in India as the tort laws. The tort laws are very clear, but I don't know how it is in the UK really, because it's the NHS and everybody is on vicarious liability.
Maybe I can add to one or 2 points. Yeah, I know of several oral and general pathologists that have stood up before courts of law and having to answer things. I think this is a highly complex question. I'll come to what I mean by that in a little while. But in the UK, I think we have a slightly different system in that I work for a hospital NHS trust, and so do my surgical colleagues, and so do my radiologists. And if the patient has a grievance, then they would take up the issue with the hospital trust. And so the grievance is with the trust, with the team, and not with the individual necessarily all the time. Dr. Kandasamy and Dr. Bhagyalakshmi can correct me if I'm wrong. But in terms of culpability, it can happen at any point. So I know of several pathologists that have been sued where they might have either overcalled or undercalled a malignant lesion, for example, and the surgeons have acted on that. Now, when is somebody culpable? Well, somebody's culpable when you can prove negligence. And in the field of pathology, negligence is sometimes based on consensus. So in the UK, if I call myself an oral head and neck pathologist, I'm duty bound to participate in an external quality assurance scheme. And so there are various steps to mitigate that. And so if I miss a cancer, the first thing that would happen is they would ask, has due process been, has it, is it an error of system? We'll break it down into sort of the pre-analytical, the analytical, and the interpretation, that sort of thing. So where did the error occur? Did it occur in the sampling? Did it occur in the processing? Did it occur in the interpretation? And in the interpretation, that's where it falls down to me. So I can get sued because I either overcalled or undercalled something that would have been out of consensus in a panel of similarly qualified pathologists. Okay, and the surgeon will not be culpable in any way. The issue, though, I think, is in placing things, having lots of steps that can mitigate against this. So the issue not necessarily, is around was something overtreated or undertreated. is what steps were put in place. So for example, we talked about that ameloblastoma. Now I showed you that example where I said, okay, this is consistent with a cyst, but it turned out to be an ameloblastoma 2 years later, and the lesion had grown. And as a result, the patient would suffer from it because the lesion had grown. Now, who was culpable? Well, in that particular instance, I retrospectively showed the same slide round to a bunch of colleagues because I have to record these things, you know, my specialty requires it. If something goes wrong, immediately the slide gets reviewed, and reviewed not by just you, but by, you know, internally as well as externally. And thankfully, in that particular case, I'm not saying this is in all cases, in that particular case, several of my colleagues within the same hospital trust and externally agreed with me that I could not have progressed beyond something that's consistent with an inflamed cyst. Had I known that there was a multilocularity and that there was root resorption, then I would have been culpable, because then at least I would have said, hold on a minute, we probably have an issue with sampling here. This is inadequate for definitive diagnosis. Please give us another biopsy. And if I'd said, if having known that there was a multilocular lesion, and if I just signed it out as consistent with inflamed odontogenic cyst, then I'm culpable. So I think the issue is far more complex and nuanced. You know, I mean, likewise, I might say, the ameloblastoma. If all I see, which may lead us on to another topic, which is the management of unicystic versus conventional ameloblastoma. If all I said was, hold on a minute, I cannot exclude a unicystic ameloblastoma, my colleagues, for them, it wouldn't be a huge problem, because at least in our institution, it would be treated like a cyst and enucleated if we were confident that it was the unicystic variant. Sometimes we get caught out because there are, you know, cystic areas, in which case, once they've enucleated it, we see conventional ameloblastoma in the wall. I would highlight that. I would pick up the phone and say, look, hold on a minute. This is not a unicystic variant. It needs more aggressive management, and hopefully the surgeon will take it further from there. So sometimes once the report comes back and once the definitive treatment comes back, may not be the end of the story. This is me sort of in a roundabout way saying, yes, the pathologist may be culpable, but we need to see where the error lied. And at least in the UK, pathologists sadly get sued quite a lot of times. Oral pathologists, not as often as dermatopathologists. Melanocytic lesions is notorious for being the most highly litigious area of diagnostic histopathology. I'm glad I'm not a dermatopathologist.
Selvam, I understand your system very well. It's very different from what we have in India. Okay, you have a health manager. The NHS is a health. I mean, there's a separate body which manages your health, and fixing liability. It's not really culpability. It's liability. You know, it's not as though culpability brings in a mens rea. I mean, a mental intent to do something wrong. It's not that you mentally wanted to do something wrong. It is. I see. It's a liability. I mean, it's just the breaking down the legal this thing. So what happens in the situation in the UK is that you have a system, like for example, if you have the NHS, there are people employed by the NHS to be a pathologist, people employed by the NHS to be a surgeon. So there is a complex, as you mentioned, a very complex situation that arises where you cannot pinpoint where exactly the problem arose from. It could be from the sampling, inadequate biopsy, inadequate, my microtome might have been, probably not functional. It could be a bad pathologist. It could be many things. And so I think it was Lord Denning in the UK. I think it was Lord Denning, but it could be somebody else as well, because Lord Denning came out with some of the most important tort laws, including negligence in the UK, who said that it is not the responsibility of a judge to decide on what went wrong where. So the organization, if it's NHS, the organization will have to pinpoint what went wrong where. And since all of you are paid employees, the liability is fixed on the NHS. It's not fixed on individuals. And it is the responsibility of the NHS to do an internal audit to find out what went wrong where and fix liability. So it's slightly different there. But in India, it's a very, very delicate area, because nobody knows exactly what happens. And under the Consumer Protection Act, it is supposed to be a commercial transaction between a patient and a doctor. It's not so much in the NHS because it's a welfare state. Health is a welfare issue. So in private practice in India, there is a liability which goes directly to the surgeon, and it's left to him to identify who else went wrong. All the others have what is called a vicarious liability, and they have to be contracts. It's very complex. I think it's probably, we need a session to actually discuss, but this is something that I think pathologists should remember, that at some point there is a liability, and I've not heard about any pathologist being sued in India actually.
Really?
Yeah.
I just, if time allows, maybe just a very quick illustrative case, which very recent is fresh in my mind. We work in a head and neck department, and we work with ENT surgeons very closely as well. And an ENT surgeon removed a melanocytic lesion in the pinna of a teenage boy, which came to me, and I reported it, and I said, look, this looks like a compound nevus, okay? But I'm a bit unhappy about certain areas. There's deep dermal mitoses, there's lack of maturation, etc. You don't need to worry too much about the morphological features. But my bottom line said, compatible with compound nevus. However, several unusual features are present. I am going to forward the case for a specialist dermatopathologist's opinion. Okay, I sent it, and the dermatopathologist pretty much agreed with me, but said exactly the same thing. Several unusual features. I think it should be re-excised because it was incompletely re-excised. And that report came back to me because it was me who sought that specialist opinion. I issued a supplementary report to the surgeon. Now, I didn't hear anything else, but I keep a note in my desk, of all the cases that I think I should follow up. Now, several months passed by, and I look on our hospital system, and the patient was never called back for a re-excision. Okay, and I'm thinking, well, where does liability lie? Should this develop and progress into a malignant melanoma? Where does liability lie? I've said I think it's such a thing. I'm going to seek the specialist opinion, and then I got the specialist opinion. I issued a supplementary report. If the surgeon didn't act on that supplementary report, where does the liability lie?
Yeah, so the surgeon.
Yeah.
The surgeon.
Yeah.
I mean, I think you were very careful. You were extremely careful. You were, most pathologists are unaware about this. And in India, I think probably all over the world, pathologists are very, very free in their diagnosis, free usage of language in their diagnosis. Consistent with clinical diagnosis is the most commonly heard way of keeping themselves non-liable. But I think that's not necessarily,
Agreed.
Actually, can I add a point as well? It's very important. I think in terms of the radiological features, Selvam and myself have come across this several times. There could be, clinically, it may not look malignant. We had a case, I think, one of our patients, there was one particular feature on imaging I was really unhappy with because the patient was treated in a different Maxvax unit for 6-7 months as osteomyelitis, had several surgical debridements, then got re-referred to our maxillofacial unit. And then they did the biopsy. The biopsy was bland, said that there was no malignancy seen. And then the surgeon continued with more surgical debridements. But when I looked at the imaging features, one unusual thing was irregular widening of the PDL. I don't know, Selvam, if you can remember the case. And I said, that is unusual for osteomyelitis because I would expect the malignancy to have that feature because the malignant cells goes along the least path of resistance. And I called my surgeon, I said that, you know what, I'm not happy about this case. Radiologically, I'm very concerned about this. Second biopsy got repeated, but still there was no malignancy seen. But I said, I'm really unhappy to discharge this as osteomyelitis. So we decided to refer this case to a Guy's Hospital where they have a head and neck unit. So they had the discussion. Eventually, part of the jaw got resected. And it was interesting when Selvam presented the pathological features, where I pointed to as irregular widening of the PDL was where the malignant cells were seen to be a squamous cell carcinoma. And we had this picture, me showing the radiological feature, what I was not happy about, and Selvam showing that that's where the cancer cells were. You know, it's a multidisciplinary approach. And I think fortunately, Candy, Selvam, Sukrit, Mittal would agree that, you know, we are more in an established system where we communicate with each other. So in terms of liability. I think we all of us take a share of it to perform our best role. If I'm misleaded at the outset, then the misleading continues into the next person, and then it becomes very, very challenging. I'm afraid in certain systems, probably in India, if you don't have such a multidisciplinary approach, it makes it even more harder. I think this may be the point Candy wanted to raise, wasn't it? Doing this as a multidisciplinary sort of meeting approach, because it's so common for us here. Any case, when it comes to malignancy, we all are so meticulously thinking of what are the possibilities, why has someone got to say about their opinion.
Right, multidisciplinary is good, but the system of healthcare is also an issue. It depends on the system of healthcare. If it's completely private, it's a totally different ball game, and if you're working for an establishment like the NHS, it's a totally different ball game. So.
And,
Yes,
and I just want to reinforce the point, and very quickly, I won't take up too much more time, but occasionally we get cases from outside hospitals for whom I'm unfamiliar with the team. And I get much more nervous when I'm looking at specimens that have been biopsied or resected by a surgeon who I do not have a nice cordial relationship with. I have to say, it's all down to relationships.
Suresh, do you have any questions coming in your direction?
Candy, you will have to answer one or two questions.
Fire away.
Okay. Different from the topic what we are discussing. So people want to know, if you want to do a marsupialization followed by enucleation, how long you want to wait? What is the time interval in between the marsupialization?
I think I've answered the question in the text form. It depends entirely. It depends on the size, the location, patient compliance, and everything. It's not a sort of a fixed answer you can give. It's only going to take 3 months or 6 months. Yeah. It is, and you also see the variations in the way it decompresses. In the ramus, it quite quickly comes down, but in the body of the mandible, it doesn't. I think it is to do with the gravity, so it quickly decompresses. So there is a different behavior in the bare anatomical side, and also the patency of the tube which we are placing, and how we are keeping it clean. There's quite a few factors. There's no easy answer to it. The maximum one I've done is there are 3 radiographs I placed. The one was the multilateral radiolucency all the way going to cornoid and condyle. That took up to almost 2 years to completely decompress into a smaller lesion for us to go back to do the final enucleation. So sometimes I use the decompression just to gain some thickening in the mandible, and again, it is up to the patient compliance. Some will constantly ring my office secretaries to bother us. I don't like this tube. I don't like this tube. You just want to, just to get into the safe margin that this can be enucleated safely without breaking the jaw. And then that's good enough for me to do it. So there's no fixed rule how long it takes, so long as patient is compliant with the treatment, and it is moving forward moving forward with a continuous reducing in size, then it is fine to wait.
Okay. So what is your decompression tubes made up of? Are they silicone tubes or something else?
No, at the beginning I even used the oxygen tube, literally made in the lab. You cut the oxygen tube to a couple of centimeters, put it in the Bunsen burner, heat it up, slightly put it against the glass slab, then that gives you a very good neck. The problem with that is the neck is not always equal, and it is slightly rougher. Patient don't like it because it's rubbing against the tongue. They didn't like it. So then finally I went to nasopharyngeal tube, size 6 or 7, which has got about 3-4 millimeter. And it has a small radio opaque line as well, so it can be clearly visualized on the X-ray. So I make sure the tube is actually sutured into hole in the bone. If you just suture it in the soft tissue, it almost always comes off, and then you have to redo the procedure again. So I suture into the bone, and also make a little holes on the side as well. So you want to get a decompression all the way around, not just on the tip of the tube. You can make holes on the side as well. Yeah, at the moment I use the nasopharyngeal tube. In the past, I thought I'm saving money by using oxygen tubes, but long term it wasn't that effective. So nasopharyngeal tube works really well for me.
Nasogastric tubes too small.
Yeah, so long as you have a silicone neck, because it is quite tolerable for the patients. It doesn't irritate the tongue if it is a silicone. If it is a plastic or if it is any other material, it does cause a traumatic ulcer on the tongue.
Logical, yes. And one last question is common to everyone. So if we treat a aggressive lesion like an OKC, what is the protocol for follow-up? Like, what is the time interval you want to see them back, clinically as well as radiologically? Shall we start with GP, sir?
Yeah, well, I told you my treatment algorithm is basically I definitely remove the overlying mucosa because I somehow trust Paul Stollinger's theory on that, and I think it's done me good, and I leave it open for about 3 months, between 3 and 6 months. With an obturator, and which is where the bunk is reduced in size, and it usually fills up in 3 to 6 months. And I tell the patient, and one thing I always do is, even if the patient comes to me with a CT, and I think I was talking to Bhagilakshmi about it, we always take an OPG as well, because all your follow-ups have to be done with OPGs. You can't keep taking CTs every 6 months or 1 year. So I do the first radiological review at 6 months, and then I do it for every year after that. And I tell them that after 5 years, you can expect that it will not come back, but I would still encourage them to drop in sometime, or if they have any, inkling that there's a problem. So at least for 5 years, we do it starting with interval of 6 months, going on to 1 year, and then 5 years is our usual thing.
Yes, sir. Do you agree, Candy? Or do you have any different protocol?
Absolutely. I'm going to include Bhagilakshmi here. In the mandible, it's a clear X-ray. You can clearly see it. There's no problem. In the maxilla, there are far too many overlapping structures, and I find it OPT sometimes not so useful. I always get Bhagilakshmi to answer that question. Let Bhagilakshmi answer that.
It's a very good point, and I agree with Dr. Paul, Prof. Paul. It's very important. I can't emphasize how much the plain film holds value in all what we see, for the very reason you can't be just repeating multiple CTs. As Candy pointed out, there have been selected cases when I write the report, when I, even the first pathology, when I say post-op, do a follow-up CBCT or a follow-up scan in 12 months' time. It depends on the lesion itself, depending on how multilocular it was and how much we expect it to be completely off. There could have been sites where you think this could be a residual lesion or it could be a scar tissue. Sometimes it's very hard to differentiate. And the cases in maxilla are the ones which we frequently bring it back more for cross-sectional imaging rather than panoramics, probably a year. You know, the case I'd shown you where it was just an incidental finding within the maxillary sinus. Actually, there was a recent scan for the patient. It was an in-between scan where things got better, but there was a recent scan where at one of the edges, it still started developing into a corticated lesion. At this point, there is no sort of overlying bone coverage. Now the issue is, has it part of it spilled into the soft tissues, or if there is the mucosal communication? And for the very reasons you all pointed out, the recurrence rate, how is it going to go? Should they take the mucosa off? And there have been selected cases where we say, go on for an MRI to actually see a soft tissue component of the lesion. So I agree, at least the first 6 months to see how much of the bone is infilled. I think doing too soon it doesn't add much. I would suggest do a post-op radiograph as a baseline because it shows your surgical changes. So not just the pre-surgical one. I think just to have a good round of post-surgical radiograph. And then from there, at least a 6 months review. And if you're happy with it, then go for a 12-month. And then if you're happy with it, then spread it into 12 months. But any point you're not happy with it, we can actually always shrink it and think of any further imaging.
Very good, Dr. Bhagyalakshmi. Thank you for your opinion. And Dr. Jimson, I think we are done with the questions. If you don't have anything else from your side, then we'll can wind up. Yes.
Just one thing, I think
Yes, sir.
with regard to the same question, I think if it's syndromic, I think you need to do a more extensive period of time because of possibility of de novo lesions coming up, recurrences, and all those kind of things. So I think
More than 5 years, sir.
More
than 5 years.
There should be a lifetime thing, really, because you're talking about other features as well, like Supreet said about the medulloblastoma. I mean,
Yes,
so in not only just the jaws, I think even other things need to be followed up, really.
Yes, sir. Understood.
I agree with Prof. because we do get the Gall-Scotland syndrome reviewed pretty much every year. And there is a very high chance of them having recurrences for a very long time.
Thank you. Yes, Dr. Jimson, yes.
Okay, I think this discussion can go on and on. It's almost 4.5 hours now. Yeah, thank you. And I would like to share a brief history about this program. When Candy conceptualized this program last year and then put forth to Veerabhagu sir, and he asked Candy to be in touch with the state association. And it was indeed a pleasure to accept the invitation what Candy put forth. At that time, Dr. Manikandan was the president, and we were very happy to accept the invite. And it is supposed to have happened in the month of April. And due to this pandemic, I think got delayed, and ultimately it has happened almost after 9-10 months. And true to the word, the multidisciplinary approach, the multidisciplinary team, and the interdisciplinary collaboration is very much required for the benefit of the patients. And the initial presentation, the first presentation by Dr. Bhagyalakshmi, followed by Dr. Selvam, everybody said the pathologist, radiologist, and the surgeon. And to add to that, now we have Dr. Mittal as well to manage the dental component. When to, if at all you need to save those teeth, yes, not in malignancies, I mean, not in the more aggressive cysts, at least whenever we want to save them, yes, he has given us tips as to how to go about doing that as well. So I think it was a fantastic meeting, and it has almost taken 4 hours, 40 minutes. So thank you all, and special thanks to Candy for initiating this and then collaborating with us and having got those fantastic speakers from your place, from UK. And
I'm lucky.
Sorry?
I'm lucky to have these guys. Honestly, they are incredibly humble, incredibly knowledgeable, no ego
and
whatsoever.
And for our very own George Pearl sir, thank you for the support. And without your support and the team from the AMS side, Tamil Nadu Pondicherry branch, it wouldn't be possible. That we have been conducting many programs, and I would like to thank the executive committee and each and every member of our state and our national association for this tremendous support. And it is not easy to have a participation of 550 plus for a webinar from a state association, and we have been consistently getting that. So it is because of the quality that we are providing for the participants. So thank you. And the moderator.
Before you finish, Jimson, I'd like to. I mean, I stick out like a thumb here because I think the oldest person here should be about a decade younger than me. I kept thinking to myself, what am I doing with these kids? I know. I mean, enormous amount of knowledge, and it really. I mean, I'm almost retiring. I'm in the process of retiring, but I think it's so nice to see so many young people contributing so significantly to the specialty. And I'd like to specifically thank Jimson and Reena and the executive committee of the Tamil Nadu State AOMSI, and Mani, of course. Mani is a very close friend of mine, and for having even thought about this idea, and Candy for having led the team, and every one of the speakers was amazing. It was fantastic. I mean, I think Jimson can go ahead with the, I thought I'd just like to intervene and give my small word of thanks.
Great to have you. It's great to have you.
Thank you, sir. Thank you. And
thank you, sir. Experience counts. Thank you, sir.
Hey, Suresh, I forgot about you, man.
You don't need to, sir.
Also, the other Indians, I mean, I think, who are on the pathologists and the Ashwath, Mrs. Ashwath and Pratibha, they were great. I mean, and Kavita as well. Sorry about it.
Thank you. Yeah, Dr. Kavita, Dr. Nalini, and Dr. Pratibha for sharing your knowledge.
Yeah, Nalini is always Ashwath Narayan's wife to me, because I know Ashwath. But,
yeah, thank you. And thank you once again. And thank you all the participants from various specialties and the general secretaries of the associations, the Association of the Endodontics, Association of Oral Pathology, and Association of Oral Medicine and Radiology, for having accepted our invitation and joining the program, and for sharing the flyers in their respective associations. And once again, thank you all. See you all sometime soon in another program. Thank you. And
thank you, Jim.
Thank you. Thank you, everyone.
Thank one more, the striker. So they're the backbone of all the programs so far, whatever we conducted from the State Association. So thank you, Team Striker, Mayank, and Chandru. Thank you.
Thank you very much, sir. Thank you very much.
Thank you all.
Thank you.
Thank you all. See you soon. Bye-bye.
Thank you. Bye-bye.
Participants, I've shared the feedback form in the chat box. You can click on the feedback and you'll receive the certificate before the end of this week in your mail. So kindly enter the correct mail ID and the name as you would like in the certificate. Thank you. Good night.
Thank you, Jim. Are we leaving?
Thank you, sir.
Thank you very much. Thank you, everybody. Bye.
Thank you so much.
Thank you.